Hi friends, in this video we're going to be having a discussion about the most important points pertaining to the topic of cell injury. So I'm starting with the discussion of general pathology. Before I start the discussion, I must remind you over here that this particular video section is not going to be a substitute for the main videos. However, this is going to be a free resource so far as a crunch time is concerned, and we wish to revise the most important points in the shortest possible duration of time. Let's get started. Now, when we talk about cell injury, we need to remind ourselves of the fact that cell injury is most commonly going to be seen because of presence of a reduced oxygen delivery at the level of the cells, or the cells are unable to utilize this oxygen. So hypoxia is the commonest reason for development of cell injury. Whenever there is going to be cell injury, the cells are going to be having differential sensitivity. If we talk about the cells in the brain, they are going to be the most sensitive cells. On the other hand, if we are talking about the cells which are fibroblasts, they are going to be relatively far more resistant. So the most resistant cell to any kind of a hypoxic damage is going to be neuron, and one of the most resistant cells that we have in the body happens to be fibroblast. Now, whenever there is going to be a presence of any kind of an injurious stimulus, the cell can either adapt itself, or it is going to be suffering from reversible cell injury, or it can possibly does not survive because of irreversible cell injury. Starting off and kicking off the discussion with the presence of discussion of something like the atrophy. Atrophy is an example of an adaptation where we find there is going to be reduce in the size and the function of the cell. So any kind of a reduction in the size and function of the cell is going to be given the name of atrophy. In most of the situations, we find that this can be because of either a denervation, or there can be something like a disuse atrophy, or there can be a reduction in the blood supply, as we have talked about in so many examples. Whenever we are going to be talking about hypertrophy, hypertrophy would be simply an increase in the size and the function of the cell. Classically, this would be visualized in case of cells which cannot divide, say for example the skeletal muscle cells, say for example the cardiac muscle cells. And we need to remind ourselves of the fact that hypertrophy is the only important example of a completely benign change, which means that under no circumstances a cell which has undergone hypertrophy is going to progress to a malignant state. In contrast, if you are talking about adaptation like hyperplasia, you have over here an increased rate of proliferation of the cells. Now, as and when the cells are going to be having a higher rate of proliferation, there is a possibility of development of spontaneous mutations, and therefore that can be possibly associated with a higher risk of development of malignancies. However, there are certain conditions which are going to be associated with a higher risk of progression, say for example endometrial hyperplasia. So that can be considered as an example of a precancerous condition. There may be other conditions in which there is an increase in the number of cells, but they remain absolutely benign. For example, the benign prostatic hyperplasia. One of the key examples of a physiological situation where you have a coexistence of both hypertrophy and hyperplasia is at the time of pregnancy, when we talk about the organs like uterus. When we are making a mention of something like metaplasia, metaplasia simply refers to a change in the nature of the cell from one important type to another type in the presence of any kind of an injury causing agent. Why that metaplasia becomes important for us to recall is because this is typically an example of a reversible change. However, if the injury causing agent is not removed well within time, metaplasia can further progress to disordered differentiation, which is given the name of dysplasia, and it can even progress to something like a neoplasia. The importance of knowing about metaplasia lies in the fact that metaplasia can either affect epithelial cells or it can affect connective tissue cells. If we talk about the best example of a connective tissue metaplasia, that would be the presence of myositis ossificans, wherein there is going to be history of an individual suffering from a trauma caused to the muscle, and subsequently you have the presence of deposition of calcium. If we talk about epithelial metaplasia, a classical example that we get is in the GI tract, wherein a patient having chronic reflux esophageal disease is going to be having a change in the nature of epithelium in the lower part of the esophagus. Another important example, and perhaps one of the most common examples of epithelial metaplasia, would be seen in case of the respiratory tree of smokers, wherein because of the smoking per se, there is going to be a change in the nature of the epithelial lining from the pseudostratified ciliated columnar epithelium into the squamous epithelium. So all in all, pretty important example that you need to keep in your mind. Now, the same question with regards to metaplasia can be given to you in the form of an image-based question, wherein they did give you an image in the All India exam, which was about the change in the nature of the cell from the right side to the left side. So in the right side, we were having a description of a cell which was having the presence of squamous epithelium, but on the left side, we were having the presence of cells which had the appearance similar to the glass vines, or what is going to be given the name of goblet. They were also shown to be having the presence of mucin. So there is a change in the nature of the cell, and therefore this kind of a change is highly suggestive of the presence of metaplasia. Another important high-yield image that we need to be remembering for the exams is what I was talking about with you earlier, wherein a patient having the presence of a chronic reflux disease would be having a change in the nature of epithelium from the highlighted stratified squamous epithelium into the intestinal columnar epithelium. Now, why do I say it as an example of an intestinal columnar epithelium? Simply because of the fact that you have the presence of glands over here, which is going to be suggestive of the presence of the columnar lining over here. The presence of the glands over here can be confirmed because of demonstration of mucin, and to pick up the mucin over here, we are going to be using a dye which is going to be staining the mucin blue in color. Easy therefore for most of us to understand and recall. The name of this kind of a dye happens to be something like Alcian blue. So Alcian blue would demonstrate and confirm the presence of mucin over here, and with that you are going to be having a confirmation of a change in the nature of the epithelial lining from the right sided squamous epithelium into the left sided intestinal columnar epithelium. Be familiar with the fact, even though I am going to be talking about this particular thing in our discussion of the GI tract videos as well, particularly in the lower part of the esophagus. Lower part of the esophagus, when there is going to be such a change in the nature of the epithelial lining, you would have a peculiar situation in which the patients in the upper part would be having their original squamous epithelium, but in the lower part, because of the constant irritation caused by the acid, they would be having the presence of intestinal columnar epithelium. So in the same individual, in the same esophagus, you're going to be having two epithelial linings, and that makes this kind of an esophagus high yield on the exams. This kind of an esophagus is what is going to be given the name of Barrett's esophagus. So the point to be understood over here is that in context of Barrett's esophagus, what is the type of metaplasia that you observe? It's the new epithelial lining by which you decide the name of the metaplasia. So the metaplasia over here is going to be given the name of the intestinal columnar metaplasia. Extremely high yield image from the perspective of your exams. Talking about the other important thing that we find whenever there is going to be presence of an injury causing agent, there is a fair possibility that the cell is going to be suffering from some kind of a reversible injury. Reversible injury therefore is going to be beginning from the situation wherein there is going to be the decrease in the blood supply, and please remember the fact ischemia happens to be the commonest cause of hypoxia. This hypoxia is going to be affecting the first organelle, that is going to be the mitochondria. Because of involvement of mitochondria, there is going to be reduced formation of ATP, so all the energy dependent processes in the cell are likely to get affected. Now, so far as involvement of the cell membrane is concerned, that is going to be associated with reduced activity of the sodium potassium ATPase pump. So there is going to be more entry of sodium inside the cell. The sodium attracts more water. That would explain the pathogenesis with respect to the swelling up of the cell, also given the other important name of hydropic change. Now, so many times examiners would ask you a question with regards to hydropic change. This increased presence of water inside the cell or hydropic change is the earliest microscopic manifestation in case of reversible cell injury. Whenever there is a reduction in the ATP, there is going to be more consumption of glycogen by the cell, so that is going to result in reduced glycogen. Because of the presence of an acidotic environment, there is going to be the presence of a clumping of the nuclear chromatin. We need to be familiar with the fact that at times, because of the reduction in the ATP availability, there is a detachment of the ribosomes, and that can be associated with reduction in the protein synthesis as well as enhanced lipid deposition. So all in all, we need to remember about the concept of hypoxia being induced by ischemia, involvement of the mitochondria, and the changes that we are going to be seeing in the different organelles in the cell. Not to forget the earliest microscopic manifestation of reversible cell injury, which is to be remembered and answered in the exam as the hydropic change. Now, talking about any situation wherein there is going to be a prolonged hypoxia, and that can be responsible for causing development of an irreversible cell injury. Now, irreversible cell injury can be having multiple patterns. One of the first patterns that I am going to talk about and revise for you over here is given the name of necrosis. Now, necrosis is going to be having further subtypes. So, necrosis simply refers to the spectrum of morphological changes that are seen in the tissue after deprivation of the blood supply. So, what we are having over here is the commonest pattern of necrosis that is seen over here is coagulative necrosis. This is most commonly going to be caused because of a reduction in the blood supply, that is going to be ischemia. Now, this kind of a coagulative necrosis is going to be typically manifesting in the form of development of a triangular shaped area, which is going to be given the name of an infarct. So, wedge shaped area or triangular area which is going to be seen because of presence of a deprivation of the blood supply is going to be given the name of an infarct. Such kind of infarcts are very common in almost all organs of the body. The important exception that you need to remember from the perspective of your exam happens to be something like the central nervous system. So, those kind of infarcts can be seen in the spleen, in the kidney, in the heart, in the intestine, but the point to be remembered is that it is not going to be seen in the central nervous system. When we talk about coagulative necrosis, there is going to be an appearance of the cells because of the presence of the retention of the cell membranes, and there is going to be a damage which is going to be given the name of the tombstone appearance. One important example of coagulative necrosis that we need to remember over here is seen in a patient suffering from enteric fever, that's typhoid, and this is given the name of Zenker's degeneration. That Zenker's degeneration classically is going to be seen in the skeletal muscles, But please remember, it's not a true degeneration. It is actually an example of coagulative necrosis. So far as liquefactive necrosis is concerned, also given the other important name of colliquative necrosis, classically seen in case of an individual whenever there is going to be the presence of CNS ischemia. The moment we talk about liquefactive necrosis, that is associated with liquefaction of the affected cells, and that is also going to be seen in case of a situation when an individual is going to be having the presence of some kind of a bacterial infection which can be associated with pus formation. So far as the liquefactive necrosis is concerned, one special type of liquefactive necrosis that we need to keep in mind is what is given the name of fat necrosis. Fat necrosis, as I wish to talk about over here, is going to be seen because of activation of an enzyme given the name of lipase. This enzyme lipase would be acting on the lipids, and that is going to be responsible for causing a damage at the level of the adipose tissue, thereby giving the term fat necrosis. Classical examples of fat necrosis can be including any organ which would be having a high concentration of adipose tissue. Say for example, an injury to the breast tissue, say for example, an injury present to the level of the mentum, or the commonest example being cited in the exams usually by the boards is a patient who is going to be suffering from a condition like pancreatitis, wherein the peripancreatic fat is going to be showing you the presence of fat necrosis. Whenever we are going to be talking about caseous necrosis is going to be a special type of necrosis which is seen in association with infection caused by organisms like tuberculosis, and this is going to be associated with a classical appearance that you see grossly of the affected area, which is like cheese-like appearance. The cheese-like appearance is explained on the presence of the fatty tissue which is going to be present in the bacterial cell wall over here. That is going to be something like the mycolic acid. As and when we are talking about the non-tubercular causes of caseous necrosis, very high point so far as an INI CET exam is concerned, you need to be familiar with examples of systemic fungal infections, for example histoplasmosis, for example coccidioidomycosis, and when we talk about the other infections like syphilis. Whenever we are talking about fibrin node necrosis is going to be characterized by the fact that we have the presence of an affected blood vessel in which there is going to be a damage at the level of the endothelial cells, and because of that plasma proteins like fibrin, fibrinogen and immune complexes can get deposited in the vessel wall. Classically, that is going to be seen in case of multiple conditions, but the commonest ones that they put up to you in the exams can be remembered with the mnemonic MAP. So malignant hypertension, when you talk about Asher's body, which is a characteristic histopathological feature in a patient suffering from rheumatic heart disease, and a condition which is a vasculitis given the name of polyarteritis nodosa, they all would be examples of something like fibrinoid necrosis. Now just to test the concept whether you could understand it, suppose I talk about an example of a condition in which a patient has been diagnosed to be having an infarct in the adrenal gland. On the microscopic examination, I find that there is a preservation of the outline of the cell. What kind of necrosis would you expect to see over there? So that was a recent exam question. The moment you hear the term infarct, the moment you read about the fact that there is a preservation of the cellular outline, it would be associated with coagulation of the proteins. And obviously when I'm using that term, the answer should be absolutely clear to you. This is going to be associated with coagulative necrosis. The other important thing about coagulative necrosis that we need to remember over here is that there is a presence of a damage to the cell membrane which is going to be very characteristically seen so far as coagulative necrosis is concerned, and that is what is going to be important in distinguishing this condition from the second pattern of irreversible cell injury which is given the name of apoptosis. So apoptosis or apoptosis, whatever way you wish to pronounce it, we need to be familiar with the fact that this is for example of a programmed cell death. That's a keyword to be remembered. That means that it is an example of a condition which can be altered by the activity of different types of genes. So far as the genes are concerned, we need to be familiar with the fact that there are genes like P53 gene, there is a gene which is given the name of BAX, gene given the name of BAC, all are responsible for increasing apoptosis. So they are pro-apoptotic genes. We do have example of genes which are responsible for reducing apoptosis as well. Say for example the BCL2 gene. Say for example we have a gene that is given the name of the BCLXL, and we have a gene that is going to be given the name of the MCL1. So all genes which are having alphabet L, they lower the apoptosis. Also, we have got certain important genes which are going to be given the name of sensors. Sensors are typically going to be asked in the context of the INI CET exam. So they are the example of genes which are going to be kind of modulating between the pro-apoptotic and the anti-apoptotic gene, and we need to remember the important example of such genes are the BH3 genes. Now, apoptosis is an example of a process that can be seen both physiologically as well as pathologically. The classical example of a physiological situation where we find apoptosis to be remembered and answered in the exam is embryogenesis. So in the fetal life, lot of changes takes place at a cellular level, and that can be explained by the process of apoptosis. Now, apoptosis can be initiated by two pathways, intrinsic pathway and extrinsic pathway. The intrinsic pathway is going to be given the name of the mitochondrial pathway. So mitochondria play a very critical role in the process of apoptosis. Any kind of a deprivation of a nutrient or any kind of a deprivation of a hormone, any kind of a radiation or stress exposure can possibly be responsible for causing point number 1, release of cytochrome C from the mitochondria into the cytoplasm. So cytochrome C has a critical role in apoptosis. That's a high yield point. The cytochrome C is going to be responsible for causing activation by attachment to what is given the name of APAF, which is apoptosis activating factor. On attachment with apoptosis activating factor, there is going to be formation of a structure which is a wheel-like structure that's given the name of apoptosome. This apoptosome is important because this is going to cause activation of caspase. Caspase, the name might as well give you a hint, is an example of an enzyme which is going to cause cleavage after the aspartic acid. And we need to be familiar with the fact that this is going to be having the presence of cysteine rich residues. So caspases are very much associated with the process of apoptosis. That's a high yield stuff. The caspase that is going to be involved so far as the intrinsic pathway is concerned over here, that is going to be given the name of caspase 9. Since this is the first caspase we are making a reference of, as we talked about in the main videos, it would be given the name of an initiator caspase. The mitochondrial permeability, which is increasing at the time of intrinsic pathway, is also going to be associated with certain types of proteins which are going to be given the name of SMAC protein and diabloproteins. SMAC and diabloproteins are going to be important because they would bind and they would neutralize IAP, standing for inhibitors of apoptotic proteins. We need to be familiar with the activation of caspase 9 becomes important because that is going to cause activation of effector caspases, caspase 3 and 7. These caspases are responsible for causing a tremendous amount of nuclear damage, so they would break down the nuclear component of the affected cell. They are also going to be responsible for causing the activation of the proteases, and all that eventually is going to be responsible for causing the cell death. So in the intrinsic pathway, we need to understand a very critical role played by mitochondria, the role played by cytochrome C, activation because of APAF, formation of apoptosome, activation of enzymes like caspases, and finally the cell dies. We obviously need to be talking about the SMAC and the diablo because they are responsible for neutralizing IAP, which is the inhibitor of apoptotic proteins. Now, the moment we are talking about the extrinsic pathway typically is going to get activated because of engagement of the receptors. Especially we talk about something like the TNF receptor, and especially we talk about the FAS receptor. So FAS and TNF are responsible for causing activation of the extrinsic pathway. As and when the extrinsic pathway is going to get activated, that would be associated with the formation of what is given the name of the FAS associated death domain. That is what I mean by FAD, FAS associated death domain, and this would be responsible for causing activation of a caspase over here. This caspase is caspase 8. So initial caspase in the extrinsic pathway is caspase 8, and please compare it with the initial caspase activated at the time of intrinsic pathway, that was caspase 9. The moment we are going to be causing activation of caspase 8, we also have a very important role which is demonstrated with caspase 10 so far as human beings are concerned, and we understand this is further going to cause activation of caspases 3 and 7. Same mechanism, tremendous damage at the level of the nucleus, nuclear being fragmented. Also, there is going to be presence of activation of proteases. Ultimately, all that is going to be responsible for causing the death of the cell. So, essentially, in apoptosis, what we are having over here is, it is an example of a process which is being controlled by genes, so programmed cell death. And what I can add over here is a word that we have a very critical role that is being played by the caspases. So that is given the name of caspase dependent programmed cell death. Of course, when we are talking about extrinsic pathway, we have to remember the role of FAS, we have to remember the role of CD95, we have to remember the role of TNF alpha, and not to forget the role of the initiator and the executioner caspases. The other important thing with regards to apoptosis which the examiners love to ask you is with regards to the important image based questions. Whenever we are talking about apoptosis, as I explained you are breaking down the nuclear into different fragments, and those fragments can be picked up with the help of gel electrophoresis. That's a pattern that they love to ask you in the exam. So the pattern that you get with the image marked as A, this pattern is given the name of the step ladder pattern. So multiple bands that you find on the gel electrophoresis, this is what you associate with step ladder pattern. This is in complete contrast to the pattern which appears to you or would be reminding you something like a blood smear that most of you have made of, that is going to be seen typically in association with necrosis. So in necrosis, what you get over here is a smear pattern, and what you get in case of apoptosis is what is given the name of step ladder pattern. Now, in the previous INI CET exams, especially the individual exams which were conducted at JIPMER as well as at PGH Chandigarh, they used to ask you about the example of techniques by which we can detect those individual fragments, And one of the techniques which was used to label those fragments was given the name of the tunnel technique. Tunnel technique. So you just need to be familiar with the fact that tunnel technique is a term that you associate with something like apoptosis. It's very, very pertinent for us to mention over here that in case of apoptosis, A for apoptosis, that is by the stepladder pattern for your ease. When we are talking about apoptosis, you please need to remember the fact that there is going to be no cell membrane damage. Because there is going to be no cell membrane damage, therefore there is usually no leakage of enzymes, and therefore in case of apoptosis, you would not have any inflammation. You would not have any inflammation so far as apoptosis is concerned. Additionally, we need to remember the fact that in case of a cell undergoing apoptosis, let me say this is an example of a cell, what we have is that there is a flipping of the protein of the part of the membrane, and because of that, what you have over here is now this molecule which was present inside the cell is going to be expressed outside, and it is immediately going to be acting as a sensor for the phagocytic cells. This rapid phagocytosis has got a special name. This is what is going to be given the name of efferocytosis. So instead of using the term phagocytosis over here, we use the term efferocytosis, which I repeat, when there is a flipping of the membrane in the cell undergoing apoptotic death, this is going to be associated with expression of a molecule on the outer surface of the membrane. This expression of the molecule attracts lot of phagocytic cells, and they would cause a engulfment of this apoptotic cell. That is a process that is going to be given the name of efferocytosis. Now the kind of molecules which are going to be responsible for causing this process of efferocytosis are going to be including molecules like C1q, and we have a molecule that is going to be given the name of phosphatidylserine. So these molecules are going to be important for the rapid clearance of the apoptotic cells from the affected tissue. The other important thing that they can possibly ask in the exam is, as and when we are making a mention of something like apoptosis, the characteristic feature of apoptosis is to be answered in the exam as chromatin condensation. So condensation of the chromatin is going to be an extremely important thing so far as apoptosis is concerned. So those will make it the differentiating features between apoptosis and necrosis quite clear to majority of you. So I just want to talk about the fact that necrosis can be only an example of a pathological process, whereas apoptosis can be an example of both physiological as well as pathological process. Chromatin condensation is the hallmark feature. There is role of mitochondria over here. There is a role of different type of genes. We do have the presence of activation of caspase enzymes. We do get something which is given the name of stepladder pattern, tunnel technique, and you need to be familiar with the concept that I just now explained you over here, absence of inflammation, and there is going to be a process of efferocytosis. So that is what is likely to take care of most of the questions that they put up to you in the exam with regards to something like apoptosis. Now we have a microbiology link over here. As and when apoptosis takes place in the liver tissue, particularly after suffering from a viral hepatitis, we do get presence of structures that are going to be given the name of Councilman body. So Councilman body actually is an example of an apoptotic body. This is going to be an example of a bright eosinophilic mass in the hepatic tissue in a patient who has suffered from viral hepatitis, and this would be quite suggestive of the presence of the cells undergoing apoptosis. So that's a key term that you need to be familiar with over here. Now talking about certain terms which are going to be pretty important for pushing our ranks to higher levels in the exam, the first important term I would like you to be familiar with over here is given the name of anoikis. Anoikis would simply stand for the fact that normal cells are going to be having an attachment with each other, and the cells are going to be having a situation that whenever they are going to separate out, they are not able to survive. So death of the cell because of the fact that they are going to be now unattached with each other, detachment of the cells resulting in cell death is what is going to be given the name of anoikis. This is typically seen in context of a lot of tumor cells. As and when we are making a mention of a process given the name of necroptosis, this would appeal to you because this seems to be a combination of necrosis and apoptosis. So necroptosis has been given two other names. It is also given the name of programmed necrosis, and it is also going to be given the name of caspase independent programmed cell death. The concept behind necroptosis that I would like to highlight over here is just going to be a quick recap. You are going to be having the release of a molecule like TNF alpha over here. This TNF alpha molecule is going to be attaching itself with the receptor. You get the role of receptor interacting protein kinase RIPK1 and 3 over here. You do have the formation of a structure which is going to be responsible for causing hole formation, the MLKL, and that is what is going to be responsible for causing death of the cell. So what you understand over here is that yes, it is an example of a process which is going to be controlled to some extent by the genes, but then it is not having the role of caspase, and therefore we use the term caspase independent programmed cell death. So watch out for a question in the exam carefully. Caspase dependent programmed cell death is apoptosis. caspase independent programmed cell death is the name given to necroptosis. Not forgetting the fact that necroptosis is having the presence of a cell membrane damage, therefore, and that is controlled by the gene, so it is also being given the name of programmed necrosis. Having said that, we talk about the third important term, which is going to be given the name of pyroptosis. Pyroptosis would classically be seen at the time of bacterial infection. Whenever there is a bacterial infection, there is formation of a structure that is going to be given the name of inflammasome. As and when we are talking about the formation of an inflammasome, this is going to be associated with the fact that there is going to be the release of certain types of interleukins because of activation of caspases. The caspases that are classically involved over here are caspase 1 and 11, and this would be associated with the release of interleukin 1. Now, because you are going to be having a release of interleukin 1, so that is likely to be associated with development of fever. That would explain the term over here, pyroptosis. So, pyroptosis, yes, the word is derived from pyrexia, and an example of cell death which is going to be associated with activation by the bacteria, formation of inflammasome, release of caspase 1 and 11, and of course, there is going to be release of interleukin 1. The moment we are going to be talking about a process that is going to be given the name of autophagy. Autophagy has been a recent favorite for your examiners, so we need to be familiar with the fact that autophagy is going to be characterized by the term cell cannibalism. Cell cannibalism. Now, it may so happen at the time of physiological conditions, say for example at the time of aging, or this may happen at the time of exercise. And of course, we can be talking about pathological conditions as well, where autophagy is likely to be seen, say for example, the presence of tumor cells. What is seen over here is that the cell is going to eat up its own organelle. Let me say this is an example of cell, that's the nucleus. You are having the presence of lysosome over here, and you have got different types of organelles which are present over here. So the different type of organelles, especially the ones which can be done away with, without which the cell can survive to some extent, they are the ones which are going to be targeted. And as and when they are going to be targeted, what is going to be happening is that they are going to be enclosed in a membrane. So there is going to be formation of what is going to be given the name of a two-layered membrane, and now this phagophore is going to fuse with the lysosome. The moment the phagophore or the vacuole is going to fuse with the lysosomal enzymes are going to destroy this organelle, and that is going to be responsible for causing the rehashing or the reutilization of the contents inside the cell. So it is a simple way. Let me say that there are 5 important organelles, out of which I find that the cell can survive without one of them. So with the remaining 4, the cell can survive. So that 1/5 extra organelle, or the one without which survival is possible, that would be targeted. It is going to be enclosed in a double layered membrane, and this vacuole is then going to be fusing with the lysosome, and that is how the process of cell cannibalism or autophagy is going to take place. Now, 3 facts I want you to remember. Fact number 1, autophagy can be seen both physiologically as well as pathologically. Physiological examples, as I made a mention of, can include aging, and that can include exercise as well. Fact number 2, the targeted vacuole is going to be a double layered membrane. Now, how exactly would you find out that which particular organelle is likely to be targeted? So, we have a marker that is going to be given the name of PELC3. Extremely important for you to remember. PE standing for phosphatidyl ethanolamine, and LC3 is going to be an example of a microtubular marker. So any organelle which is likely to be kind of damaged because of its fusion with the lysosome subsequently, that can be picked up with the help of this kind of a marker. So they may ask you the name of the marker by which you can tell about the cells undergoing autophagy or exact organelle which is going to be undergoing autophagy. That is going to be the PELC3. Also, we need to remember the fact that autophagy is something which is going to be controlled by genes. Couple of genes that we need to have an idea would be including the ATG5 gene, and of course there are other ones as well. It has been shown that for a lot of neurodegenerative disorders, say for example Alzheimer's disease, autophagy has got an important role. We do need to be familiar with the fact that in case of a neurodegenerative disorder like Huntington's disease, it has got a role. In a patient having tuberculosis, autophagy has got a role. In a patient who is going to be suffering from inflammatory bowel disease, also it has been shown to be having a role. So autophagy, keywords to remember are just 4 important points. Cell cannibalism. You need to remember formation of a double-layered membrane. You need to remember the marker, that is PELC3, and you need to be familiar with the physiological and the pathological example of conditions which are going to be associated with this phenomena of autophagy. Not to forget the basic concept, a redundant organelle is going to fuse with the lysosome, and you are going to be rehashing, reutilizing the contents which are going to be derived thereof. Now, one important example of a special type of a cell death that we need to be familiar with over here is what is mentioned in our books now, and that is given the name of ferroptosis. Ferroptosis. The moment we are talking about ferroptosis, the first important hint I want you to pick up from this particular term is ferro. So this is going to be an example of an iron dependent process. Iron dependent process. What is going to be seen over here is going to be a simple fact. Because of the presence of an iron dependent process, this is likely to be contributing to the development of lipid peroxidation. And as and when we are making a mention of lipid peroxidation, that automatically would translate into the fact that there is going to be presence of a free radical injury. So the moment we are talking about something like ferroptosis, what is going to be seen over here is that there is going to be a situation when there is availability of too much of iron, which is going to be responsible for causing development of lipid peroxidation. And this is going to be characterized by an important fact, as some of you may be able to remember the fact. Remember this organelle that I talked about earlier as well. There is going to be therefore loss of the mitochondrial cristae, and there is going to be a damage of the outer membrane protein. Outer mitochondrial membrane is what is also going to be having a damage. So lot of mitochondrial cristae. This is, as your books make a mention, an ultra structural characteristic finding of ferroptosis. So iron dependent pathway, formation of free radicals because of lipid peroxidation, damage to the mitochondrial cristae, as well as there is a damage at the level of the outer mitochondrial membrane. This is what is going to be responsible for causing an enhancement in the permeability. Now when there is going to be an enhancement in the permeability of the plasma membrane, this is what is going to be contributing in the death of the cell. Now we need to be familiar with the fact that ferroptosis is an example of a process that is going to be regulated by specific signals. Essentially also because this is an example of an iron dependent pathway. So the moment you are going to be reducing the concentration or availability of iron, this is an example of a process which is going to be reduced. So reduction of the availability of iron is likely to reduce the death of the cells because of the process of ferroptosis. Talking about now the quick recall of the concept of free radical injury. Now as and when we are talking about something like free radical injury, we just need to remind ourselves of this particular pathway wherein we have the availability of oxygen getting converted into superoxide. The superoxide is then going to be responsible for getting converted into hydrogen peroxide, and that is because of availability of an enzyme which is given the name of superoxide dismutase. This hydrogen peroxide can be responsible for the formation of the most powerful free radical, and that's a 2 times asked question which is going to be answered by you in the exam as hydroxyl radical. This hydroxyl radical has been shown to cause a free radical damage at the level of different types of cells, tissues, even microorganisms. Now whenever we are talking about hydrogen peroxide, this is going to be responsible for the formation of hydroxyl radical, but then you would require the help of transition metals like copper and iron. Whenever there is going to be a role played by iron over here, the ferrous form is going to get converted into the ferric form. This reaction is going to be given the name of Fenton's reaction, and a very important biochemistry pathology interlink question. We also need to be familiar with the fact that in order to neutralize this hydrogen peroxide, we can be having the role that is being played by catalase enzyme. So direct transformation of hydrogen peroxide into water. The second possibility is hydrogen peroxide is going to get converted into water with the help of reduced glutathione, and as and when I am making a mention of the reduced glutathione, this is going to be undergoing a cycle because of the enzymes like glutathione peroxidase as well as glutathione reductase. So this particular pathway is something that we have talked about in detail, and we read about that in biochemistry as and when we talk about the damage being to the RBC being reduced because of presence of these enzymes. Also, we need to be familiar with the concept of Fenton's reaction. We need to be familiar with the hydroxyl radical. The similar pathway is what is going to be extremely important so far as the killing of a cell is concerned when we are talking about the white blood cells. So in the white blood cells, essentially the neutrophils, the oxygen is going to get converted into superoxide because of an enzyme NADPH oxidase. At the time of infections, the body wants to eliminate as many bacteria as possible, and that would be requiring more amount of free radicals. That free radical supply is coming because the WBCs are now going to consume extra amount of oxygen. Remember the process that is given the name of the respiratory burst. So these are the important points that we need to remember so far as this kind of a flow chart is concerned. Now important facts that I would like you to be familiar with over here is free radical injury is going to be an example of an autocatalytic or an example of a self-sustaining process. Free radical injury also acquires significance because of the fact that this is as of now the most accepted reason for the development of aging. It is also postulated that if, and that was what was asked to you as a recent NEET PG 2022 question as well, when we are going to be having a desire to reduce the process of aging. Now this can be achieved by multiple mechanisms, but one of the most effective mechanisms happens to be calorie restriction. You heard that right, calorie restriction. When I use the term calorie restriction, what I mean to say over here is that the individual has to reduce the calorie intake by 30% without causing malnutrition. Remember that. reduction by 30% without causing malnutrition. That is what is being meant by calorie restriction. However, there are going to be problems in real life so far as sustained calorie restriction is concerned. So this is going to be supplemented with the help of administration of certain types of drugs, and therein we can talk about the drugs which have been given for promotion of weight loss as well. For example, drugs like maybe metformin, or we talk about a chemical like resveratrol. A third important mechanism by which aging can be reduced to some extent can be the presence of somehow physical activity. But then, as they say, physical activity even on a regular basis, say for example, has been shown to improve the quality of life, but it is not been proven to actually reduce aging. So far as the reduction of aging, or I would say reversal of aging, is concerned, that is something which can be achieved with the help of calorie restriction most importantly. Now, how calorie restriction can be responsible for reduction of aging is because calorie restriction, point number 1, is responsible for reducing the damage caused by free radical injury. Also, we have the role that is going to be played by certain types of molecules which are going to be given the name of sirtuins. Now, these sirtuins are responsible for enhancing the cell survival. So, when we want to reverse aging, we have to increase the levels of sirtuins inside the cell, and sirtuin levels can be increased by only two known mechanisms. One, that an individual is going to indulge in calorie restriction, and the second mechanism by which sirtuins can be increased is going to be the consumption of red wine. So that is not going to be a stimulus for any individual to take alcohol, but then those are the important things that you must remember with respect to the concept of free radical injury. Now, no amount of discussion about free radical injury can ever be complete if we don't talk about the different examples of mechanisms by which the formation of free radicals can be reduced or interfered with. So definitely we have the role that is going to be played by different types of vitamins, say for example vitamin A, C and E. They all are going to be given the name of the antioxidant vitamins. Essentially, enzymes like SOD, enzyme like catalase, enzyme like glutathione reductase, they all are going to be given the name of the enzymes which are going to be responsible for protecting a cell from the free radicals. Now, why that becomes important is, suppose there is an individual who has got a problem at the level of the SOD gene. So the SOD or the superoxide dismutase will not function properly, and as a result of which this has been implicated in the development of a condition that is given the name of amyotrophic lateral sclerosis. I hope most of you would be remembering that bucket water challenge. So amyotrophic lateral sclerosis is implicated in individuals because of a problem at the level of SOD. Additionally, whenever we are talking about free radical injury, we are familiar with an example of a pigment which is going to be an indicator for free radical injury, and that kind of pigment is what is now appearing on your screen. It's an example of a perinuclear golden brown pigment, which, as most of you can recall very well, this is going to be given the name of lipofuscin. So lipofuscin, which is going to be associated with the term wear and tear pigment. It's also called by the name of pigment of aging. It is also going to be associated with the term that it is going to be associated with cachexia, associated with a patient who is going to be suffering from cancer, and of course elderly individuals. The moment we are talking about lipofuscin, this is going to be derived from lipid peroxidation. We need to be familiar with the fact that at a microscopic level, especially electron microscopically, you would be having the presence of lysosome, which is going to be appearing over here. So apart from the perinuclear location, this is going to be having the location. It is going to be an example of a pigment which is going to be located inside the lysosomes. And therefore, we understand the fact that because of its association with aging, usually we find that there is a decrease in the size of the cell as well as function of the cell. That is what we talked about earlier, atrophy. And because of its brown golden color, lipofuscin would be associated with the term, and that is given the name of brown atrophy. So all those are important keywords for exam: wear and tear pigment, pigment of aging, example or a telltale sign of free radical injury, perinuclear location, golden brown pigment, especially deposited in the cardiac tissue and the hepatic tissue to a greater extent, intralysosomal location on the electron microscopy. And not to forget the fact that this particular pigment is going to be a very important pigment so far as the free radical damage is concerned and associated with the term brown atrophy. Now talking about an example of a pigment which is said to be the only important example of an endogenous black pigment, and when I use the term, that's a big time hint which the examiner wishes to share with you. This is going to be the pigment which is given the name of melanin. So melanin is responsible for giving the color of our skin and hair, and the example of the only important endogenous black pigment. Of course, if somebody was to ask you the most important example of an exogenous black pigment, you would answer it as like what? You would answer it as something like the coal dust. As and when we are making a mention of something like melanin, melanin is identified with the help of a special stain, and the name of the special stain may be a potential question for the exam. That is given the name of the Masson-Fontana stain. Masson-Fontana stain in the exam is not to be confused with the Masson's trichrome stain, which is typically used to demonstrate the deposition of the fibrous tissue, including collagen, in multiple conditions, which we are going to be talking about subsequently. So Masson-Fontana for the demonstration of melanin in the skin. Of course, if they were to talk about an example of a question which typically talks about a child who is going to be having the passage of urine which turns black on color on exposure to air, you would be thinking in terms of a condition that is going to be given the name of L-captonuria. So in context of L-captonuria, the important point that I would like you to be familiar with over here, yes, there is a black pigmentation, but that black pigmentation over here is going to be seen at multiple tissues. Say for example, in the urine on exposure to air, as well as in case of other soft tissue. And when there is a soft tissue involvement because of the deposition of the black pigment, that is what is going to be given the name of ochronosis. Of course, the biochemistry link L-captonuria can be seen because of deficiency of an enzyme, which is going to be given the name of homogentisic acid oxidase. The moment we are going to be talking about the next important pigment, that is going to be something like hemosiderin. Hemosiderin, loved by our examiners for multiple reasons. Fact number one, this is an example of a pigment which is going to be derived from iron. So it's an example of an iron derived pigment which is going to be seen especially in those areas of the body where iron is going to be stored. So it can be seen in the macrophages in the bone marrow, can be seen in the macrophages in the liver as well. Now to demonstrate the presence of iron, we are going to be using a special stain, and that kind of a special stain is what is going to be given the name of Prussian blue. Iron is going to be getting a good reaction with Prussian blue, responsible for the formation of the ferric ferrocyanide, and that is going to be responsible for a term Pearl's reaction. So those dark blue violet color granules that you sometimes see over here are going to be suggestive of the fact that the individual is going to be having excessive amount of iron deposition. Now classically, the conditions where you would find such a picture where there is too much of an iron can be because of genetic conditions. Say for example, we talk about conditions like hemochromatosis, or we use the term hemosiderosis, or we can be talking about conditions, say for example, a patient who is suffering from a blood disorder like thalassemia, and this individual has been given repeated blood transfusions. So two conditions that you need to remember, of course, genetic condition, that would be something like hemochromatosis, and of course you need to remember about thalassemia patients receiving multiple units of blood transfusion. Even that can be responsible for causing too much of deposition of hemosiderin, and this is going to be manifested in the form of those blue to dark colored granules, which are going to be highly suggestive of the presence of something like Pearl's reaction. Talking about the next important pigment that can be asked in the exam, we are going to be having a discussion about the deposition of calcium. The important thing to be remembered over here is that calcium is going to be having a basophilic appearance in the routine hematoxylin eosin staining. However, we are going to be using at times special stains for picking up calcium. One which is going to be given the name of alizarin red, the other one which is going to be given the name of von Cosa stain. The important point that we need to remember over here is that calcium is going to be having a red color when you are going to be using alizarin red. So that's an easy way to remember. Say for example, you talked about the term Prussian blue. So iron is going to be getting a bluish appearance. Similarly, alizarin red is going to be giving a red appearance to calcium. On a similar fashion, von Cosa stain is going to be giving a very black appearance. So black appearance or a dark appearance that you are going to be having with the presence of calcium. In the exams, the question with regards to the presence of calcium can be an example of an indirect question wherein they talk about deposition of calcium in the medial layer of the blood vessel, a condition which I presume a lot of you can recall from the main video section. In the vascular disorders, we talked about that in the section under CVS, a condition given the name of Monkey-Burg sclerosis. So you demonstrate the presence of calcium deposition, because of which the vessel becomes hard, and that's going to be a pretty hard thing for an individual when taking pulse, when palpating the pulse of an individual. When we talk about and have comparison between alizarin red and von Cosa, we need to remember that alizarin red can pick up even minimal amounts of calcium. That's an important thing. And reiterating the fact, in hematoxylin eosin staining, calcium is going to be having basophilic appearance, von Cosa black, and alizarin red a reddish appearance. Now there were two patterns of calcification that we talked about. One wherein degenerated or dead cells were having deposition of calcium in spite of normocalcemia. That's given the name of, yes, you understand it right, dystrophic calcification. So I hope you remember the example of conditions where we have dystrophic calcification. Dystrophic calcification could be seen in case of rheumatic heart disease, could have been seen in case of atherosclerosis, could have been seen in case of certain types of tumors. And when you're talking about tumors, these are the important ones that I especially want you to recall quickly. M for meningioma as well as mesothelioma, O standing for the papillary cancer of ovary, also given the name of serous cystadenoma, papillary cancer of salivary gland, papillary cancer of thyroid, prolactinoma, glucagonoma, all those examples of tumors which are known to have calcium deposition. Now because they have calcium deposition, the calcium deposition in them takes place in a peculiar fashion wherein the calcium is going to be having a deposition in a concentric ring-like fashion, and that is what is going to be given a special term that is going to be termed as semoma body. So basophilic deposition of calcium in concentric ring-like fashion is what is going to be given the term semoma body. Additionally, we need to be familiar with the fact that there was a second pattern of calcification in which, because of hypercalcemia, the calcium was getting deposited even in the living tissues. So that is what is being given the name of metastatic calcification. Metastatic calcification. The moment we are talking about metastatic calcification, we think about conditions associated with hypercalcemia. For example, the disorders like primary hyperparathyroidism, parathyroidadenoma. We talk about chronic kidney disease. We think in terms of vitamin D intoxication, sarcoidosis, multiple myeloma, milk alkali syndrome, and example of conditions in which there is going to be osteolysis, bone destruction because of metastasis. So two different patterns of calcium deposition, dystrophic and metastatic, and examples of each of them which the examiners love to ask you time and again. When we're talking about calcium deposition classically can take place in a situation wherever there is a presence of an alkaline environment, and the commonest important organ in the body affected by calcium deposition is lungs. So far as organelles are concerned, I mean, if you compare nucleus, mitochondria, let's say Golgi apparatus, endoplasmic reticulum, you find calcium has got a special affinity to go and get deposited in the mitochondria. In fact, that is going to be one of the important reasons why at the time of reversible as well as irreversible cell injury, you have calcium deposition in the mitochondria being responsible for the presence of a feature given the name of mitochondrial densities. So coming back to our discussion over here, these are the important examples of the stains which are used to pick up calcium, and of course the two different patterns of calcification that we need to be familiar with. Talking about the next important example of a pigment about which we need to have an idea, that is going to be talking about the deposition of lipids. Now lipids in general, as a lot of you understand friends, has a property that lipids and glycogen tend to get washed away when we are doing the preparation or fixation of a slide. So fact number one, when you have to see the presence of lipids, when you have to detect lipids, you have to ensure that the tissue is going to be frozen. And how do you ensure that? That is going to be ensured with the help of an important instrument that is given the name of cryostat. So frozen sections are going to be taken so far as detection of lipids is concerned. Now when we are talking about lipid detection, we have one of the very good stains which is going to be given the name of oil red O. Oil red O, as the name gives you a hint, oil, so that is going to be fat or lipid, and when we are talking about red, the fat or the lipid is going to be getting a reddish appearance. Now this is an example of a superior stain and pretty commonly used so far as detection of lipids is concerned. As an alternative, what you need to remember is that we can be at times asked a question in the exam on a second important stain which is going to be given the name of Sudan black. Name gives you a hint again. Lipids are going to be getting what kind of a color with Sudan black? Yes, you're going to be getting the presence of a black color deposition in the tissue. So oil red O is going to be giving you a red color deposition, whereas black color deposits are going to be seen with Sudan black. Examiners may try to ask you clinical history based questions wherein they talk about the deposition of lipids, say for example in the mitochondrial damage in a patient who has been given or suffering from Reyes syndrome. Remember Reyes syndrome, child having presence of a viral infection, and then this child has a development of fever. In order to treat his fever, you gave this child aspirin by mistake, and that aspirin is responsible for causing the presence of damage at the level of the mitochondria. So that was again an example of a classical situation in which we are going to be having the presence of the lipids being detected at the level of the mitochondria, and with the help of stains like oil red O, and of course we are going to be using cryostat, we can make the detection of lipids very easy. Talking about the next important material, we need to be familiar with the presence of a proteinaceous substance that is given the name of amyloid. Amyloid is an example of an extracellular material which is typically going to be deposited outside the cells or the tissues, and therefore it is going to result in organomegaly. Now detection of amyloid can be done with the help of a very common stain that is going to be given the name of Congo red. The Congo red is going to be giving a pink red appearance to the affected area, and that is what you can make out over here, the pink red appearance in the affected area. But under the polarized light, the same amyloid is going to be having a shiny appearance. So three facts that we need to remember. Fact number one, amyloid is going to be extracellular deposition of a proteinaceous material. The most characteristic appearance of amyloid is the presence of this apple green birefringence. But please remember that is going to be observed only and only under polarized light. Be familiar with the fact that the commonest stain which is being used is Congo red, and on staining with Congo red, the appearance of amyloid protein that we get over here is the presence of a pink red appearance. So that is what we need to have an idea so far as the deposition of amyloid is concerned. Of course, we are going to be talking in detail about amyloid in the section of immunity. Talking about the next important stain that has been asked in the exam in an indirect fashion, this is a stain which is going to be responsible for picking up the presence of the connective tissue material that is going to be given the name of Masson's trichrome stain. The moment you hear the term tri, that means 3, chrome means color. So this is an example of a stain which is going to be providing a bluish color so far as the deposition of the collagen is concerned. It provides a black appearance to the nuclei and it gives a reddish appearance to the muscles over there. So that is the reason. But the primary purpose of using a Mason's trichrome stain is as and when you want to confirm the presence or deposition of the fibrous tissue or collagen, as we are going to be talking about subsequently, say for example in the renal section, in which I am suspecting that my patient could be having the development of a chronic glomerulonephritis. I'll be showing you that image as well, but that is where you're going to be using a stain like Mason's trichrome stain. I talked about this fact earlier, a few minutes earlier. Please remember and read the question carefully. Mason's trichrome stain is not to be confused with Mason Fontana, which was the stain which we were using for. Yes, you know that, right? That was used for the detection of melanoma. So this is about Mason's trichrome that we need to have an idea. Now looking at this kind of an image which we discussed few minutes earlier as well, but then the question was about not about Barrett's esophagus. The question is about the detection of acidic mucin. So as and when we are talking about acidic mucin, this was present in context of Barrett's esophagus in the presence of goblet cells, and this acidic mucin can be picked up with the help of a stain. The name of the stain that you need to be familiar with for exam is given the name of Alcian blue, which explains the fact why you're going to be having that bluish appearance so far as the cells over here are concerned. So easy for us to remember as well. A for acidic mucin is going to be having a bluish appearance which is going to be seen because of it being detected by Alcian blue. Of course, the commonest condition which has been asked in the exam so far is detection of Alcian blue and mucin in a patient suffering from Barrett's esophagus. The kind of metaplasia that you would expect to see in these patients happens to be, I repeat that again, intestinal columnar metaplasia. Now looking at the next important image which appears in your screen, you have the presence of a green background in which you can be observing quite clearly the presence of orange colored spots. Now this is because of the presence of the use of a stain which is given the name of acridine orange. So as is going to be the golden rule for remembering, most of the appearances or acridine orange is going to be giving an orange appearance to the nucleic acids, particularly the DNA, RNA, and it becomes very clearly visible because of the presence of a green background. So that is what we need to have an idea so far as acridine orange is concerned. Talking about the next important stain, this particular stain that I wanted to be familiar with, friends, and which has been asked in the exam couple of times recently is given the name of toluidine blue. Now toluidine blue is especially responsible for picking up or detection of mast cells in the connective tissue. That is one important use of toluidine blue. This is an example of a metachromatic stain, which practically means that you are going to be having two different colors, one color in the background and the second color of the desired cell. So in the background you can observe that there is a presence of a bluish background and the mast cells are going to be having the presence of a dark color. So this dark color that you're going to be getting in the mast cells is because of the fact that you are going to be having this purple appearance because of presence of the intracellular contents of the mast cells, including the acidic contents with which this particular drug, the stain, the toluidine blue, is actually going to react. Another important use of toluidine blue apart from the detection of something like the mast cell would be in context of detection of squamous cells, and that is what is going to be used quite commonly so far as when we are having a strong suspicion of an individual who is going to be suffering from oral cancer. So toluidine blue is going to be having a special affinity so far as the nuclear material is concerned, and as we understand, if there is going to be any kind of an abnormal proliferation, if you are talking about a cancer, there is going to be an increase in the nuclear cytoplasmic ratio. The higher nuclear content is something which can be detected easily with the help of staining by toluidine blue. So two places where toluidine blue is going to be extremely effective. One, it is useful for detection of mast cells because of the metachromatic staining, blue background and purple colored granules. And fact number two, toluidine blue also is going to be giving you an abnormal pattern of staining as and when a patient is going to be having an oral cancer, something as you find over here, a patient who is going to be having the cancer of the tongue over here. The next important stain that I wanted to be familiar with over here, which has been asked in the exam, is what is going to be given the name of the Sweet's reticulin stain. Now, fact first, when we are talking about reticulin, most of us need to remember our anatomy well. This is going to be made up of collagen subtype 3. And as and when you are going to be using the sweet stain, what you are going to be having is in the green background, you are going to be having the presence of the black colored reticulin fibers. Now, typically this kind of a stain is quite commonly useful for detection of the deposition of the reticulin fibers in the hepatic tissue. So three facts with regards to Sweet's reticulin stain. Yes, reticulin stain gives you a hint. It is responsible for detection of reticulin fibers. Fact number two, reticulin fibers are going to be made up of collagen subtype 3. And fact number three, where exactly are we going to be using this? It is quite commonly useful for detection of reticulin so far as the hepatic tissue is concerned. The next important example of a stain which has been asked quite commonly and which is used in the histopathology lab happens to be the PAS stain. Now PAS stain has got a property. This is responsible for having a reaction or interaction with glycogen, and as and when PAS has an interaction with glycogen, it is responsible for giving a dark magenta color, which can be very clearly observed in the slide. Now you would read in a question so many times that PAS is going to be used along with diastase as well. You see what is going to be happening is if you are directly going to be using PAS, it is going to interact with glycogen and it is going to be giving a magenta color. Suppose we initially use diastase. Diastase is going to be causing a dissolution of the glycogen, and after using diastase, if you are going to be using PAS, then what you are going to be finding over here is that PAS would not be able to pick up the glycogen because now it has been degraded, it has been broken down, and therefore both of them are going to be used together so far as detection of glycogen and the conformation is concerned. It is, however, very important for you to remember that PAS is not an example of a specific stain. Why do I say it is not an example of a specific stain? Because with the help of PAS, you can detect the presence of, and this is what I want you to note down over here clearly, basement membrane. This can be useful for even picking up something like the mucins. But remember the kind of mucins that you commonly pick up with the help of PAS happens to be neutral mucins. Acidic mucin, you are using Alcian blue. Neutral mucin, you are using PAS. It can also be useful for picking up certain types of fungi. And it can be useful for picking up apart from the basement membrane, neutral mucins fungi, this can be useful for picking up something like the glycogen. So apart from glycogen, 3 other uses of areas where we are going to be using the PAS. So that is going to be the fungus, the basement membrane or tissues, as well as we are going to be using it for the detection of something like the neutral mucins. So that is about PAS that you need to have an idea. The next one about which we need to have an idea is what is going to be given the name of the Gomorrhe's methenamine silver stain. Gomorrhe's methenamine silver stain. Now this is typically going to be useful, and you would read about that as and when you are going to be wishing to detect the presence of fungi. So with the help of this kind of a special methenamine silver stain, the fungus is going to be having a black appearance. Now depending upon the morphology, you can be actually detecting the different types of fungi. Say for example, you have an individual who is suffering from some immunocompromised condition, and post that he is going to be having a fungal infection. So the presence of the fungus can be confirmed with the help of something like the Gomorrhe's methenamine silver stain. So have that particular thing in your mind that the silver stain over here is going to be giving the fungus a black appearance. Now in your exam, friends, they have even asked you the different types of parts of an object like microscope, which is obviously going to be one of the key instruments which is going to be used in the path lab. So this is going to be the head, as we understand. This is going to be the arm from where you actually going to be picking it up, of course being cautious that you do not let it fall. There is going to be presence of what is going to be given the name of objective lens over here, the lens over there. You are going to be having the presence of the focus knob, which is going to be altered by you so as to have a better resolution of what is present in your slide. This is going to be the stage where you're going to be keeping your slide. This is going to be the condenser, and the light is going to be coming from below. That is going to be the illuminator, of course. The microscope is going to be resting on the base. So just have a look at the different types of parts of a microscope, because in the future they may give you a question wherein they put an arrow at a particular part and they expect you to be aware about the special name which has been given to this particular part. The kind of question which had been asked in the exam earlier was an image quite similar to this one. So they did ask you an image about this. So this was the head, obviously. This is going to be your objective lens as I described. This is going to be your stage. However, the pointer in the exam was towards C. C happens to be condenser and D happens to be the illuminator, because of which you are going to be visualizing the slide clearly. So those different parts of the microscope is what you need to be aware of over here. Of course, when we are talking about the microscope, we are going to be talking about the different types of magnifications. So routine magnification or low power magnification, that would be 10x. If you are talking about high power magnification, that can be 40x. If you are going to be using still high power magnification, you would be using something like the oil immersion, the objective lens, and that is going to be giving you a power as much as 100x. So those are the important values that you need to have an idea when we are talking about something like the parts of a microscope. The next important technique which is importantly asked in our exams is what is going to be given the name of flow cytometry. Now in flow cytometry, you are going to be having the presence of fluid, in which you are going to be having the presence of this sample containing the cells you wish to have a look at. Now these cells are going to be then tagged with antibodies, and because of the presence of a laser beam, you are going to be actually looking at the presence of the fluorescence which is going to be being emitted from the different types of cells. So suppose one particular cell has got one molecule, and because of it there is a particular type of antibody that gets tagged with this cell, it is going to emit a different kind of a fluorescence. Similarly, if there is going to be a second molecule and there is a second antibody, there is going to be a different type of fluorescence, and these can be picked up with the help of the scatters which are going to be observed. So the sample is going to be put from here. There is going to be the cells which are going to be flowing in a single line. You are going to be having the antibodies which are going to be also added over here, and then there is a laser beam which is obviously going to be a single focus beam, and there is going to be emittance of the fluorescein which is going to be seen from the stained cells. Now, two types of scatter which we need to be familiar with. One, as you find the name over here, is given the name of the forward scatter. The forward scatter is primarily dependent upon the size of the cell. Size of the cell. So the bigger the cell, the more is going to be the forward scatter. So far as the side scatter is concerned, the side scatter is dependent upon granularity of a cell. Now, with the help of flow cytometry, this is going to be having a very important use so far as hematology is concerned. Say, for example, for detection of different kind of leukemias, flow cytometry is currently going to be majority of the cancers. For them, it is going to be the investigation of choice. How exactly are you going to be having a representation of the flow cytometry graph? You can be having a representation in the form of those histograms, or you can be having that in the form of the dots. So dots and histogram, there are two important ways by which you can detect and you can kind of show the presence of the different types of cells. Let me show you one important example of the kind of a graph that is going to be typically, just for the random sake, which is going to be appearing to you. So this is going to be the presence of the x-axis, and then there is going to be the y-axis. On the x-axis, you're going to be usually having some kind of a molecule that you wish to detect. And on the y-axis, you are going to be having the number of cells who are going to be having the expression of such a molecule. Say, for example, if you're talking about on the x-axis, we are having the presence of CD8. On the y-axis over here, we have another molecule CD4. So we can understand that a lot of these cells, about 23% of the cells are going to be CD8 positive. There are going to be cells, 44% of the cells which are going to be CD4 positive. There are cells which are having no expression of either CD4 and CD8, they are going to be 31%, and there is a small percentage of cells, 1%, which have expression of both CD4 as well as CD8. So depending upon how exactly are you going to be making a representation, that is going to be the dot-like representation. You would divide the flow cytometry graph into different quadrants. If you are talking about this particular quadrant, let me just take that opportunity to label the quadrants for you. Let me say if this is with the quadrant 1, any cell falling in this category will be having a high expression of both X as well as Y axis molecule. Any cell that is going to be falling in the category of quadrant 2 is going to be having the higher expression of Y molecule but not the X molecule. Any cell which is falling in the category of quadrant 3 is going to be having low expression of both X as well as Y molecule, and any cell which is going to be falling in the category of quadrant 4 is going to be having a high expression of the molecule present on the Y axis. So x-axis, sorry, do excuse me on that. So depending upon the cells which are going to be lying in different quadrants, you can easily make out that which particular cell is going to be having the expression of which particular molecule, and that's exactly what is useful for making a detection of lot of conditions. Talking about the next important instrument, this is going to be the appearance of the instrument which is given the name of high performance liquid chromatography, which is asked in exams primarily in the context of the questions on hematology, wherein you talk about the detection of hemoglobinopathies. Of course, the gene sequencing would remain the foremost and the best important technique by which we are going to be detecting the presence of any kind of a hemoglobinopathy. But so far as detection of a hemoglobin is concerned, this kind of a machine is going to be used, and the advantage of using this machine is it is going to be giving you a pattern wherein it would tell you not only the qualitative nature of the hemoglobin that is present in your sample, but it would also give you a quantity of the hemoglobin that is present in the sample. Say for example, the graph over here shows you the presence of almost 30% of hemoglobin A. It also shows you the presence of almost 30% of hemoglobin S. So all of you can make out what exactly is the likely diagnosis for this individual. He is having normal hemoglobin as well as he is having hemoglobin S. So this is an individual who is going to be suffering from sickle cell trait. So the graph is what we are going to be getting so far as the nature or in the quantity of the hemoglobin is concerned, and that is the example of the instrument which is going to be given the name of high performance liquid chromatography. Here we are going to be having a discussion about a quick recap of the process of inflammation. Now please recall the fact that inflammation is the response of the vascularized connective tissue to any kind of a noxious stimulus. When you talk about inflammation, it can be having multiple types of sub patterns. There can be presence of serous inflammation, you can be having mucinous inflammation, you could be having presence of purulent inflammation, you could be having presence of fibrinous inflammation. But the commonest pattern of inflammation that we see clinically happens to be what is given the name of catarrhal inflammation. As and when we are making a mention of the term inflammation, it can be of two important major subtypes. We can be having a short duration acute inflammatory process, or we could be having presence of a chronic long duration inflammatory process. Having a look at both these processes, we are going to be having two important components. One is changes inside the blood vessels, which would refer to the vascular changes, and the second would be the changes that you see inside the white blood cells, referred by the name of cellular changes. As and when we are making a mention of the vascular changes, there are four important types of vascular changes which are typically asked to us in our exams. The very first vascular change you need to recall, though it has been deleted from the latest edition of Robbins, would still be answered in the exam as vasoconstriction. So I repeat that earliest vascular response in injury is to be answered in the exam as vasoconstriction. This being a transient phenomena is then going to be followed by the release of chemical mediator induced vasodilation, and the commonest chemical mediator contributing to vasodilation is going to be answered by you in the exam as histamine. More chemicals are going to be released at the local site of inflammation, thereby going to be responsible for causing an increase in the vascular permeability. I highlight the increase in the vascular permeability for the simple fact that this is going to be the most characteristic vascular change associated with acute inflammation. So the hallmark feature with respect to the vascular changes of acute inflammation would be highlighted and answered in the exam as increased vascular permeability. Now that increased vascular permeability, as for those of you who have watched the video in the main section, would be recalled by the fact that there are multiple mechanisms by which permeability can be increased. The commonest mechanism that you need to remember from the perspective of your exam happens to be endothelial cell contraction. This endothelial cell contraction takes place immediately and it is an example of a temporary phenomena. So you would alternately given it the name of immediate transient response. Classically, this kind of an immediate transient response would be seen when we are talking about a vasodilation or increase in permeability that is associated with, let us say, a thorn prick, a previous INI CET question. The other mechanisms by which increased vascular permeability can be seen can be with respect to a condition that is going to be given the name of endothelial cell injury. And when we are talking about a direct endothelial cell injury, that is going to be given the name of an immediate sustained response. The immediate sustained response is what you find when there is going to be a direct endothelial cell damage, which is going to be seen because of, let us say, a patient who has been exposed to a very high temperature burns, or say, for example, in case of severe systemic infections like septicemia. Other mechanisms are also going to be observed. Say, for example, we can be talking about something like endothelial cell retraction, wherein there is a reorganization of the cytoskeleton, and we talk about something like endothelial cell damage, which is going to be associated with the presence of a delayed prolonged response, something that you see in kind of a late developing sunburn. So watch out for the table from the main video section and you should be very clear about examples of each of these mechanisms. I repeat, the commonest mechanism for increased permeability happens to be the presence of the immediate transient response, which is the endothelial cell contraction. Now predominantly with respect to the blood vessels, there is an involvement of the smaller blood vessels, and most commonly affected vessels over here usually happens to be the post capillary venules. Subsequently, what you find is that there is going to be leakage of fluid from the vessels, thereby there is going to be a reduction in the velocity of blood flow, which is being termed as stasis. So those are the four options that they give in the exam. Depending upon how they're going to be framing the question, you can answer it accordingly. Talking now about the second component that we are having, that is going to be cellular changes. So we understand the fact that when we are looking at the inflammatory cells, we are going to be having the cells over here. They first need to move inside the vessel and subsequently there are changes that we observe outside the vessel. So I can always divide the cellular changes into intravascular and extravascular cellular changes. We can recall from our discussion that intravascular cellular changes would start with the fact that the cells moving in the center of the vessel would first come to the periphery, that would be given the name of margination. This margination is then going to be followed by the appearance of speed bumps on the surface of endothelial cells. Molecules, I believe you can recall, which are given the name of selectins, which are responsible for rolling and loose adhesion. Watch out for that particular word in the question in the exam. When we are talking about the firm adhesion, that is because of another important molecule that is going to be given the name of integrin. And this firm adhesion actually is what is being given the name of integrin mediated adhesion. So firm adhesion is what is being termed as adhesion, and subsequently finally we are going to be having the presence of diapedesis, the movement of the white blood cells across the basement membrane, which is pretty much rich in collagen type 4 as well as laminin, the most abundant glycoprotein as you are aware of, and you are going to be having the movement of the WBCs from within the vessel to outside. Recall the fact that diapedesis is going to be contributed by a molecule given the name of CD31, which is also being given the name of the platelet endothelial cell adhesion molecule. Now, one very important image which is likely to be helping you out so far as cracking question the exam is concerned is with respect to something like the role played by selectins and integrins. So selectins are going to be involved in the process of loose adhesion as well as rolling. They are going to be having an interaction with the molecule that is given the name of silyl Lewis X. Recall from our discussion, a possible defect in case of a metabolism of an enzyme given the name of fucosyltransferase can contribute to the development of a condition where the affected individual is going to be suffering from a trouble that is given the name of LAD second. Such individuals are going to be having a short stature, they would be having presence of Bombay blood group, and they are going to be having increased risk of infections. When we are talking about a trouble at the level of integrins, integrins are expressed on the surface of white blood cells. They interact with complementary molecules on the surface of endothelial cells, which are given the name of intercellular adhesion molecule, that's ICAM, and vascular cell adhesion molecule, that is VCAM. Any problem at the level of integrins is going to be associated with a trouble. The patients would be having a development of LAD first. So easy for us to remember, and that's a memory trick that I told you in the main videos as well. Now recall that LAD first is going to be associated with the clinical presentation in case of a child who is going to be having the presence of a history of delayed separation of the umbilical cord at the time of birth. So pretty important history. These children are going to be having the presence of neutrophilia, even though there is going to be scanty pus formation. They are going to be having the presence of repeated history of attacks of infections. So recurrent infections, plus you take the history from the mother and she would tell you the fact that yes, the umbilical cord took a lot of time for it to get detached. Yes, you're going to be having a trouble that the patients would be having infections. Still, there is going to be minimal pus formation that you see, and primarily that can be explained because the WBCs are not able to reach the site of the damage or the inflammation. So those are the important terms that you associate with, or the molecules that you need to remember over here. Coming then to talk about the molecule that you associate with something like extravascular changes. Extravascular changes would begin when the WBCs have already gone through this process, they have already moved out over here, and then they have a target to which they are supposed to be attacking. So we have talked about that with the help of a very beautiful analogy as well, wherein we talked about the fact that the white blood cells are going to get attracted because of the presence of certain chemicals. Those chemicals are going to be responsible for a unidirectional movement of the white blood cells. That's the process that is given the name of chemotaxis. So single directional movement of the white blood cells. Chemotactic molecules can be external molecules, or they can be examples of endogenous molecules. External molecules would include something like bacterial products. Endogenous molecules would include complement proteins, C5a, leukotriene, LTB4, and molecules like interleukin 8. We do have the next important process taking place, which is being termed as opsonization. Opsonization simply referring to the fact that once the white blood cells are coming near the bacteria, then the white blood cells are going to be preferentially taking up or eating up those cells which are going to be covered by chemicals given the name of opsonins. So examiners love to ask you about that preferential killing word. Opsonization is the word that you need to remember. They would ask you the name of the chemicals required for opsonization. So that would include something like C3b. You would be having the role played by plasma proteins like fibrinogen. You would have the role that is being played by the mannose binding lectin. We definitely have the role that is going to be played by the other important molecules, say for example the immunoglobulins. Understanding or recalling that fact that if there is going to be any condition in which there is going to be a hypogammaglobulinemia, that can interfere with opsonization. So one example of a condition which your examiners love to go after time and again is a condition that is given the name of Bruton's disease. Bruton's disease, remember, we discussed that in immunodeficiency disorder, disease of boys, X-linked recessive disorder, the condition characterized by B cell defect. Precise defect is a defect in the enzyme B cell tyrosine kinase signaling. We are going to be having a trouble at the level of formation of antibodies, and therefore these patients are going to be having defective opsonization. Once the white blood cells have targeted, they have logged a particular bacteria, they are going to engulf the bacteria. That is the process which is going to be given the name of a pseudopod extension, and that pseudopod extension takes place because of the important role played by the molecule called by the name of actin. So actin polymerization is going to be associated with pseudopod formation, and due to that particular process, what we observe is that now the white blood cell is going to engulf the bacteria. Once the bacteria is going to be engulfed, it is going to be present now inside a vacuole. So now we have the role in which this trapped bacteria, this vacuolated bacteria is going to be eaten up by, it is going to be destroyed by the WBC, and that process is obviously going to be given the name of killing. Now recalling from our discussion earlier, this killing can be of two important subtypes. Point number one that I would like you to understand over here, once you have a bacteria which is present over here, the bacteria has to be brought near the lysosome. That's because of the courtesy of a protein given the name of the lysosomal transfer protein. Any problem with lysosomal transfer protein, you can understand the bacteria would not come near the lysosome, and I would like you to be familiar with the example of the condition. The condition I'm referring to is Shediac-Higashi syndrome. So I'd shown you the pic of a guy, usually a boy, who's going to be having the presence of albinism. He's going to be having the absence of the melanin pigmentation on the skin as well as on the hair. He's going to be having the history of development of repeated attacks of infections. He would be having the presence of platelet defects. He's also going to be having the other manifestations, like there usually can be development of some kind of associated neurological manifestations at time. And one of the characteristic features of celiac Higashi syndrome lies in the fact that there is going to be presence of giant granules in the peripheral smear. So that's a very, very important hint for the exam. Failure of fusion of lysosome with the phagosome because of a List protein defect. That's what you associate with the celiac Higashi syndrome. Now, talking about the killing part of it, the killing can take place by mechanisms which do not use oxygen and by mechanisms which definitely use a good amount of oxygen. This mechanism is responsible for the formation of free radicals and therefore a much more powerful mechanism by which the bacteria are going to be killed. Having a look at the oxygen independent mechanism, we have the role played by different types of proteins. Say for example, we have arginine rich proteins which are given the name of defensins. We do have a role that is being played by a protein that is given the name of cathelicidin. We have a very important role that is being played by eosinophilic basic protein. So eosinophilic basic protein is going to be responsible for the formation of free radicals, and those free radicals specifically toxic for parasites. So when we are talking about eosinophilic basic protein, that is actually going to be given the name of the major basic protein, and major basic protein toxic to parasites coming from eosinophils. So in parasitic infections, that would explain the eosinophilia. Additionally, we can recall from our discussion in the main videos that eosinophils get attracted at the site of inflammation because of the presence of certain cytokines. We'll talk about that again, but as of now, remember, it's the role of interleukin 5 and to a smaller extent interleukin 4 which attracts the eosinophil at the site of a parasitic infection or at the site of an allergic infection. Having said that, talking about the role of oxygen dependent mechanism, so we understand the fact that oxygen is going to get converted into superoxide anion. That's because of the enzyme NADPH oxidase. Recall from our main videos, NADPH oxidase is also given the name of respiratory burst oxidase. This is going to be responsible for the formation of hydrogen peroxide. With the help of an enzyme given the name of myeloperoxidase, you would get the formation of hypochlorous radical because yes, there is going to be entry of the halide ion. This hypochlorous radical incidentally is going to be responsible for causing a damage at the level of the bacteria or the infectious organism. This hypochlorous radical incidentally is also going to be the major free radical that is produced at the time of the bleaching powder coming in contact with water, which is another important question asked in your exams. Any kind of a trouble at the level of myeloperoxidase would result in enhanced risk of infections. Similarly, if there is a trouble at the level of NADPH oxidase enzyme, that would result in the manifestation of a disease given the name of chronic granulomatous disease. Now, chronic granulomatous disease is characteristically characterized by the fact patients would be having the development of repeated attacks of infections, and those infections from a microbiology link we can recall are going to be caused because of catalase positive organisms. In terms of bacterial infections, I would recommend you to be recalling Staph aureus. In terms of fungal infections, Candida. So repeated attacks of infections because of catalase positive organisms, because of NADPH oxidase enzyme defect, that's what is going to be observed over here. Undoubtedly, patients would be having the presence of granulomas in multiple organs in their body. Though we have availability of the flow cytometry in the current times and we have the availability of the dihydrorhodamine test, but one of the important tests which the examiners love to ask you time and again, the nitroblue tetrazolium test. So nitroblue tetrazolium test is useful for diagnosis of which particular problem at the level of the WBCs. The answer is pretty clear: chronic granulomatous disease. Management of the patients, definitive management is with respect to something like bone marrow transplantation. Otherwise, we get a very important role that is being played by interferon gamma. So that is what we need to recall so far as the intravascular and the extravascular cellular changes are concerned. Now we have a look at the inflammatory chemical mediators quickly. Now talking about the chemical mediators, and that would just remind me of the fact that we need to be familiar with certain important terms which are likely to be asked in the exam, especially as the trend is there. We are being asked about set of processes that we need to have an idea. One is neutrophil extracellular trap, which I'm sure most of you are going to be familiar with the fact. Septicemia is going to be associated with platelet activation. That platelet activation is responsible for activation of an enzyme which is given the name of arginine deaminase. So remember that enzyme name, arginine deaminase, responsible for causing conversion of arginine into citrulline. Practically, that neutrophil extracellular trap would be translating into the fact that you have a neutrophil like this, but the nuclear material of a neutrophil is now going to be extending itself outside. So that is responsible for the formation of a meshwork, and into this meshwork the bacteria are likely to get trapped. Now that neutrophil extracellular trap is important because one, it can be activated at the time of severe infections. Point number two, the neutrophil which is going to be undergoing this kind of extension of the chromatin material would not be able to survive itself, but that is a sacrifice that the neutrophil is doing in order to reduce the chances of bacterial infection. In association and extension of the same facts, in the chromatin and the nuclear antigens are now being exposed to the systemic circulation and the immune cells. So this is associated with a higher risk of development of systemic lupus erythematosus. So you need to remember about septicemia term, platelet activation term, arginine deaminase, arginine to citrulline, and the fact that this condition or this mechanism, this process is going to be associated with the higher risk of development of the autoimmune disorder like SLE. When we talk about phagocytosis, that is to be differentiated from two other terms which are quite commonly given in the exam. In phagocytosis, what you are primarily doing is that you are going to be digesting most of the times a dead cell or a dead bacteria, right? But what you are doing in context of emperipolysis is a situation which has been asked as an image-based question as well. You have big cells, say for example over here you have the presence of a megakaryocyte, and this megakaryocyte has actually engulfed a white blood cell. You appreciate over here the presence of a band cell. Now this cell, which is a bigger cell, is in a living state. The cell which has been engulfed is also in a living state. So it is a cell within a cell phenomena that takes place. But the good point is both the bigger cell as well as the cell which has entered into this, both of them are going to survive. You do not find, I repeat that, you do not find any kind of a morphological change in either of the cells. So it is just a phenomena wherein a big cell is going to engulf a smaller cell, staying inside for some time over there, spending some time happily and merrily, and then coming out without any kind of a morphological change. And this kind of a phenomena of emperipolysis quite commonly is observed in case of conditions like autoimmune hepatitis. If you have already watched the videos of autoimmune hepatitis in the RR section or in the main section, remember the fact we are talking about emperipolysis over there. We talk about something like hepatic rosette over there. We talk about the presence of the interface hepatitis over there. So if you haven't, then please do ensure that you have a look at those images which are very high for the exam. Apart from autoimmune hepatitis, you do have the role of emperipolysis that is being played in context of a disorder which is given the name of the Rosai-Dorfman disease. Rosai-Dorfman disease. And definitely emperipolysis can also be seen in case of other disorders, but these are the two most important ones which are to be remembered. Of course, your books would make a mention of something like maybe myelodysplastic syndrome or at times in case of other conditions. But the fact is, cell within a cell, no morphological alteration, none of the cell dies, both the cells survive, and especially remember those conditions, Rosai-Dorfman as well as autoimmune hepatitis. Now, what was asked to us in a recent exam was with respect to something which is given the name of entosis. Entosis is also given the name of cell within a cell. Then how is it going to be different from emperipolysis and phagocytosis? Entosis is going to be different because what you are having in case of entosis is a simple fact. You have one important cell, you have another important cell, and let us say these cells are going to be present in close contact with each other. And let me say for the sake of example, this is going to be an example of the basement membrane. Now when there is going to be an attachment of the cells, there is going to be presence of a molecule between them which binds them or glues them. You remember that molecule, E-cadherin. Suppose of a situation, typically as in case of a tumor, what you have over here is that there is a separation of the cells from each other. There is a loss of E-cadherin molecule, as well as what you find is the cells are going to separate from the extracellular matrix material. So both the cells are of same type, they are similar in nature, and one cell is actually going to engulf the other. I mean, the superimposition would make it a bit difficult for you to understand. So I'm just trying to help you understand. Let me say that this is an example of I would say a more aggressive kind of a cell. So I would call it as a dominant cell. And this is a more meek kind of a cell, relatively weaker cell. So the dominant cell, what it is going to be doing is it is going to be eating up the meeker cell. Now, the difference between this process and emperipolysis simply lies in the fact that in case of emperipolysis, you had a bigger cell, you had a megakaryocyte engulfing something like a neutrophil. So big cell is going to engulf the smaller cell, right? But over here, the cells are of similar type. So it is just by the sheer property that one cell happens to be a bit stronger than the other, and the bigger or the dominant cell is going to eat up the meeker cell or the weaker cell. Now after some time, the meek cell is going to be staying inside over there, and then finally it is going to die. So in contrast to emperipolysis, it is not that both of the cells are going to survive. The weaker cell over here is going to die. Now, what is the significance knowing about this entosis? Obviously, you would understand that this is a cell within a cell phenomena. You appreciate the fact it is going to be different from phagocytosis and emperipolysis, but the clinical aspect of this particular fact is that over a period of time, let us say when we are talking about a cancer or a tumor, especially in case of the tougher times for a cancer, when there is a reduction in the vascular supply, you would have the cells which are more sturdy, the cells which are more aggressive, the cells which are going to be dominant, they would eventually utilize the limited resources and they would eat up the weaker cells. So eventually, as the cancer is going to progress, or as the cancer is going to be facing a hard time because of, let us say, reduction in the vascular supply, you would be having a subclone of the cells which are much more aggressive, much more sturdy. So we need to understand the fact that entosis, in the recent exam they asked you the question, this is what is being given the name of cell within cell phenomena, but watch out for that particular fact as to the difference between the terms emperipolysis, entosis and the term which is phagocytosis. Now, having said that, we come back to our discussion wherein we talk about the role that is going to be played by chemical mediators. The chemical mediators can be present either inside the cells or they can be present in the plasma. The moment we are going to be talking about the cell chemical mediators, they can either be example of preformed or they can be example of freshly formed mediators. Now, when we talk about the preformed mediators, just few seconds of a recap that would include histamine, serotonin and lysosomal enzymes. So out of them, the very important role is being played by histamine coming from the mast cells, and the histamine present in the mast cells you can pick up with the help of a special stain. So many times in the recent exam they have asked you this question on picking up the mast cell. The name of the stain happens to be toluidine blue. We need to be familiar with the fact serotonin is also going to be having a role which is quite similar to histamine, and then definitely the role is also going to be played by the lysosomal enzymes. Now, talking about the important freshly formed mediators, they would include something like nitric oxide, they would include cytokines, and we do have the role that is going to be played by arachidonic acid metabolites. Talking about the points with respect to nitric oxide, that's an example of a gaseous chemical mediator, and this chemical mediator is going to be coming from the amino acid source happens to be something like L-arginine. Particularly at the time of a non-inflammatory condition, we have the role that is going to be played by the endothelial cells. So we have the enzyme which is given the name of ENOS, whereas the inducible form of nitric oxide synthase is important at the time of inflammation. Of course, for the sake of completion, we need to be remembering the fact that NNOS is also present, that is usually present in the nervous tissue. Having said that, talking about the cytokines can be subdivided into different categories. So we are going to be having the cytokines which are going to be the cytokines that appear on your screen. Examples of pro-inflammatory cytokines would include interleukin 1, interleukin 6 and TNF alpha. Remember the fact that these cytokines are responsible for contributing to the systemic effects of inflammation that we talked about in detail, having the effects in different organs in the body, including the liver, including the brain and the general condition of the individual. We need to be familiar with the fact that all these systemic pro-inflammatory cytokines can be responsible for causing an induction in fever. However, what we just need to remember over here is going to be a simple fact that one important member of the interleukin family, and I want you to specifically remember it, interleukin 18 is not associated with development of fever. So they have given you a question in the exam wherein they did talk about interleukin 1, they did talk about the role played by TNF alpha, they talk about ciliary neurotrophic factor, but I repeat, interleukin 18 which belongs to the interleukin 1 subfamily is not going to be associated with development of fever. When we are talking about anti-inflammatory cytokines are going to be interleukin 10 and TGF beta. This is important because TGF beta is also going to be an example of a cytokine which is going to be important at the time of healing. So it is a pro-fibrotic type of a cytokine. It is very important for the development or deposition of the fibrous tissue in the tissues after the development of inflammation. When we are talking about cytokines which are going to be having a dual action, we have a role that is associated with interleukin 4 and interleukin 6 primarily, and definitely we could be talking about the ones which are going to be having sometimes an additional action. A special example of a cytokine which has been asked in the exam relatively recently is interleukin 11, which is also going to be having an anti-inflammatory action. At the same time, I would like you to be familiar with the fact that we have the role that is being played by different types of interferons. So if you can remember and recall, interferon alpha, beta and gamma, alpha coming from all leukocytes, beta coming from fibroblasts, and interferon gamma is going to be coming from the T cells. This interferon gamma is going to be responsible for causing macrophage activation, formation of epithelioid cells, and plays a very important role in granuloma formation. So the interferon gamma is going to be useful in the management of a patient suffering from chronic granulomatous disease. Having said that, we need to be familiar with the fact that these cytokines are going to be acting on the liver, especially the pro-inflammatory cytokines, and then they are going to be responsible for increase in the concentration of certain proteins given the name of acute phase reactants. Now, the moment you talk about acute phase reactants, you would think in terms of something like the different types of proteins whose concentration is going to get increased. We do have certain molecules whose concentration reduces at the time of inflammation. So, they are going to be given the name of the negative acute phase reactants. Just to give you an example of either of them, when you talk about positive acute phase reactants, that would include proteins like, let us say, ferritin. When we are talking about a negative acute phase reactant, we have proteins like transferrin, as well as we have the role that is going to be played by a protein like, let us say, albumin. Hepcidin, another important example of a positive acute phase reactant, which plays a critical role in the process of, in the pathogenesis of anemia of chronic disease. One new example of a positive acute phase reactant about which you definitely need to have an idea, which was included in the latest edition of Robbins as well, is given the name of thrombopoietin. Having said that, I would just like you to have a look at the different types of chemokines. Alpha chemokine includes the primary example interleukin 8, which is responsible for causing and attracting the neutrophils. The beta chemokines includes the eotaxin and the RANS that is primarily associated with activation of the eosinophils. So eotaxin might as well give you a hint. Lymphotaxin, which is an example of a gamma chemokine, is responsible for attracting the lymphocytes. When you're talking about the CX3C, that is going to be fractalkine. Now, all in all, what I want you to remember over here is at least the names should be looked at least once. Make sure that you're writing them with your own handwriting once. Make a sticky note for them. Have a look at them intermittently, and rest assured you will be able to recall that information in the exam very comfortably. Now, when we are going to be talking about something like the chemical mediators which are going to be present outside the cells, that would include the chemical mediators in the plasma. But we just need to have a look at the arachidonic acid metabolite table, even though this is usually likely to be covered with you in biochemistry as well as in pharmacology. Arachidonic acid is going to be an example of an important 20-carbon fatty acid, which is going to be responsible for giving us different important subtypes of inflammatory chemical mediators. Now, this arachidonic acid is going to be produced because of action of an enzyme phospholipase A2. Recall the fact this is an example of a rate limiting enzyme. Arachidonic acid can be acted upon by an enzyme that is going to be given the name of COX enzyme, which appears on your screen, and this COX enzyme is responsible for the formation of molecules like the prostaglandin G2 and H2. From prostaglandin G2 and H2, because of action of the isomerase enzyme, you would be getting the formation of something like prostacyclin. Prostacyclin, the formula is PGI2, coming from the endothelial cells and plays a very important role because this is going to contribute to vasodilation, as well as it is going to be an anti-platelet aggregatory molecule. So, it is responsible for reducing the chances of platelet aggregation. The other important molecule that can be produced from prostaglandin G2 and S2 is going to be the prostaglandins like prostaglandin D2, E2 and F2. They have certain common actions, out of which prostaglandin E2 in particularly is loved by the examiners for the simple fact because this is the one which is going to contribute most specifically to the development of fever as well as pain. So, this particular prostaglandin E2 is going to contribute to the development of fever at the time of infections. When we are going to be talking about something like the third important chemical mediator, that is going to be thromboxane A2 coming from primary sources platelets, and this molecule is going to be contributing to vasoconstriction. That's one action. It also is responsible for increasing the chances of development of platelet aggregation. So, all these chemical mediators are very important. They have been repeatedly asked in the exams, and please do not goof up on them. Just make sure that you revise them time and again. On the other hand, we can be having an action of 5-LOX or the lipoxygenase enzyme over here, which can be responsible for the formation of hydroxy penta icosahexatetraenoic acid, that is 5-HPTE, and that is going to be giving rise to the leukotrienes. Recall the fact that leukotrienes like leukotriene C4, D4 and E4 are going to be given the name of SRSA. That would be the slow reacting substance of anaphylaxis. Leukotrienes are very powerful bronchoconstrictor agents. So, they are going to be playing a very important role so far as the spasm of the airways is concerned, which would make them extremely important target molecules so far as pathogenesis of conditions like bronchial asthma is concerned. Having said that, just a simple link of pharmacology that we have drugs which can be targeting this molecule, this enzyme, that is going to be something like the corticosteroids. COX enzyme can be inhibited by the example of drugs like the aspirin, like the non-steroidal anti-inflammatory drugs, and as and when we are going to be talking about something like the 5-LOX enzyme being targeted by a drug like xylitol, we do have the drugs which are going to be blocking the action of the leukotrienes, drugs like, let's say, the montelukast and zafirlukast. So, this particular table is going to be like extremely important. Now, talking about the chemical mediators present in the plasma, we talk about the first important chemical mediator, that is going to be a chemical mediator that is going to be given the name of the kinin system. The kinin system, as we have made a mention of the fact, quite commonly asked in the exam, is getting activated because of the presence of Hageman's factor, which is the other name of factor 12. The factor 12 is going to be responsible for the formation of kallikrein. Kallikrein subsequently is responsible for the formation of bradykinin. Understand the fact that factor 12 is also going to be playing an important role in the coagulation cascade. A third role of factor 12 is it is by the kallikrein, it is also responsible for causing a conversion of plasminogen into plasmin, and this plasmin therefore is going to be important for fibrinolytic pathway. So I want you to remember that factor 12 or Hageman's factor is responsible for activation of three pathways. This is what we tend to remember: formation of bradykinin. The second we tend to remember, activation of coagulation cascade, and the third that we tend to remember, and we need to remember that for the exam, activation of even the fibrinolytic pathway. Why that becomes important is because bradykinin plays a very important role at the time of inflammation. For acute inflammation, the chief role of bradykinin is increased permeability. In physiology, read about bradykinin because it is going to be responsible for causing development of pain. And we do have a role that is being played by the breaking down of bradykinin by an enzyme that is given the name of the ACE enzyme. So when we talk about the ACE inhibitors in pharmacology, they elevate the levels of bradykinin that contributes to the pharmacological action of ACE inhibitors as antihypertensive agents, but at the same time they also contribute to the development of an adverse effect, which is going to be dry cough. Additionally, bradykinin, because it increases permeability, can contribute to development of angioedema in patient who has been given ACE inhibitors like captopril, lisinopril, ramipril, fosinopril, and the drugs that you're all familiar with. Having said that, we talk about the second important chemical mediator in the plasma, which is the complement pathway. Complement pathway, very important for fighting out infections. In fact, one of the important plasma proteins, which is an integral component of not only the innate system, but via the secretion of the antibodies coming through the B cells, is also going to be an important bridge between the classical or between the innate pathway and the adaptive immunity. So when we are talking about the complement pathway can be activated by three important subtypes. One can be the classical pathway, which is going to be having the role that is being played by antigen as well as antibody, and that is going to be responsible for causing activation of complement proteins C4 and C2. They subsequently cause activation of C3. C3 is then going to be responsible for activation and breakdown of C5, and that would be ultimately responsible for the formation of MAC. Having said that, the second important pathway can be what is given the name of lectin pathway. You have the role played by mannose binding lectin, and that again through the similar process is going to cause the formation of membrane attack complex. When I use the term membrane attack complex, so many times has been asked in the exam, the formula for MAC happens to be C5b-9. On the other hand, when we are talking about the alternate pathway, typically activated because of gram-negative infections, that means endotoxin exposure, at times can be activated because of presence of something like maybe IgA antibody. Please, however, recall that in the classical pathway, you are getting the important role played by IgM and IgG antibody, right? Whereas in alternate pathway, the name gives you a hint, it is IgA that is playing a very important role. Now, irrespective of the initial pathway, whether it is an alternate pathway, whether it is a classical pathway, whether it is a lectin pathway, the story is going to be getting summarized to the fact that you would be having the formation of MAC. Now, this MAC is going to punch holes in the target bacteria or the antigen, and it is going to destroy it. But we have the role played by other complement proteins, which has been asked in the exam time and again. So C3b is very important for phagocytosis because it is responsible for opsonization. C3a and C5a are important because they are going to be acting as chemotactic agents. We also need to understand the fact C3a, C5a are going to be functioning as anaphylotoxins. And by anaphylotoxins, what I just mean to say is that they can be responsible for activation and degranulation of the mast cell, thereby causing a release of histamine. So isolatedly, C3b required for opsonization, isolatedly C5a required for chemotaxis, C5a and C3a required as anaphylotoxins, and definitely we need to be having a role that is going to be played by MAC in the lysis of microbe. Complement system proteins are also going to be having the important role that is being played by regulatory proteins. Important example of a regulatory protein that I would like you to make a mention of over here is going to be C1 esterase inhibitor. C1 esterase inhibitor prevents excessive unnecessary activation of the complement proteins. So if there is going to be any deficiency, of C1 esterase inhibitor, that is going to result in the development of a condition which is going to be given the name of hereditary angioneurotic edema. And for the sake of simplicity, I'll take the liberty of writing it as hereditary angioedema, an example of a non-pitting edema classically seen in females, affecting the oral mucosa, affecting the lips, affecting the tongues, can even cause a manifestation like diarrhea in the patient because of involvement of the gastrointestinal mucosa. We need to be familiar with the fact that we can be having a role that is going to be played by regulatory proteins, which are commonly asked in the exam: factor B, factor D, CD46. And the importance of knowing about these factors is that if there is going to be any trouble at their level, they can contribute to the development of a condition that is going to be given the name of atypical hemolytic uremic syndrome. Of course, if we are talking about the major complement proteins, say for example, we are going to be talking about the role that is going to be played by C1, C2, C4, any kind of a defect in them, any deficiency of them can increase the risk of development of autoimmune disorders like SLE. If there is any problem at the level of C3 protein, that is going to be associated with a higher risk of development of multiple types of infections. That is what we need to be having an idea about. Also, if there is going to be a definition or deficiency of late proteins C5 to C8, that would exacerbate development of infection caused by the organisms like, say for example, toxoplasma. That also exacerbates the infection caused by the gram-negative diplocoi. That means the Neisseria like organisms are going to be having a higher risk of development of infections in these patients. Important for us to recall that C9 complement protein deficiency usually does not result in development of any kind of a disease. So having a look at that kind of a table, drawing it all by yourself just about couple of times, having a look at it time and again will ensure that you crack all the questions in the exam pertaining to the complement system. So now we are going to be talking about the coagulation cascade, which is the third important example of the chemical system present inside the plasma. Of course, just for the sake of a quiz like question, if I were to ask you an example of a disease which comes to your mind, a hematological disorder which comes to your mind, if the patient is going to be having a trouble at the level of the complement proteins CD55 and CD59, you would be able to answer that hopefully by this point of time. That is going to be answered as the paroxysmal nocturnal hemoglobin urea. Now talking about now the coagulation cascade. So far as the coagulation cascade is concerned, activated by two pathways, the intrinsic pathway and the extrinsic pathway. Now with respect to the extrinsic pathway, that is what I call by the name of the short sweet pathway, there is going to be a release of tissue factor. That's usually the physiologically more important pathway that is responsible for causing activation of factor 7. This factor 7 is then going to be associated with activation of factor 10, going to cause activation and formation of thrombin, and that is going to be associated with formation of fibrin. On the other hand, as and when we are making a mention of the intrinsic pathway, it is going to be activated because of the clotting factors coming in contact with the negatively charged surface. So in the lab, you would do it or ensure it with the help of something like bringing them in contact with a glass surface that causes activation of factor 12. After that, there is subsequent serial activation of factors 11, the 9 and 10, and that is going to be further then going to be responsible for the formation of thrombin and fibrin. Fibrin being an example of a strand-like molecule get polymerized in the formation of a stable fibrin clot, but then the important role for the stable formation of a clot is because of presence of factor 13. If we were to just recall simple questions with regards to coagulation cascade, yes, coagulation cascade is going to be playing a very important role so far as the formation of thrombus is concerned. But what they love to ask in the exam is thrombus formation can be associated with the triad which is given the name of Virchow's triad. You can recall the fact the Virchow's triad is going to be associated with endothelial cell injury. You can be having the presence of hypercoagulable state, and what you can be having over there could be the presence of a situation when there is going to be the presence of an altered blood flow or turbulence. We need to be familiar with the fact that as and when we are making a mention of the clot formation, most important role is being played by endothelial cell injury, because that causes the activation of not only factor 12 but also causes release of an amount of tissue factor which can activate the extrinsic pathway. Out of the clotting factors, certain clotting factors are going to be vitamin K dependent. So they are factors like 2, 7, 9 and 10, out of which factor 7 is the one which is going to be having the shortest half-life. So a very important question with respect to the clinical vignette question that they gave you in the exam, wherein a patient was described to be having a deficiency of vitamin K, and then which of these factors was likely to be deficient. We understand the fact that in case of certain situations, for example, pregnancy, this is an example of a hypercoagulable state. Majority of the clotting factors are going to increase, but we have an important exception, that is with respect to factor 11. So factor 11 is the one which is going to go down. It decreases at the time of pregnancy. That is also what you need to keep in mind. We also need to be familiar with the role that is being played by protein C and protein S. Protein C and protein S are example of molecules which are responsible for inhibiting factor 5 and factor 8, because they inhibit factor 5 and factor 8. So you can understand the fact protein C and protein S are example of anti-clotting proteins. We also need to be recalling the fact that for the monitoring of the intrinsic and the extrinsic pathway, for the extrinsic pathway, we are going to be using a parameter in the lab given the name of prothrombin time. The prothrombin time in the current times has been replaced by a new parameter that is going to be given the name of INR. That's the international normalized ratio. If I have to check for the activity of the intrinsic pathway, I would be doing a test that is going to be given the name of APTT. So both these tests become important. Say for example, when we are talking about a patient who is suffering from a bleeding disorder like hemophilia. In hemophilia, you will be getting the role of a defect at the intrinsic pathway level. So the value of APTT is expected to shoot up. Similarly, if you are talking about a patient who is going to be suffering from a history of chronic alcoholism, he develops a liver disease, and or the patient who is going to be having a GI malabsorption disorder, because of which he is having a steatorrhea, because of which he loses vitamin K, and that is going to be initially manifesting in the form of elevated levels of PT, or a better term I would use is INR. Recall the fact that if you have to check for the complete coagulation profile in case of an individual, something very commonly done by the anesthetist prior to a surgery, especially when a patient comes to us in the ER, that particular test is going to be given the name of thromboelastography. So you get a complete information about the coagulation profile, how exactly is the clot form, how exactly is the fibrinolytic pathway working. All that profile is being beautifully coming to you as an information when you talk about a test that is given the name of TEG, that is thromboelastography. There are going to be questions in the exam which are going to be with respect to specific conditions in which we are going to be getting an alteration of the APTT as well as PT, which is the one which we are going to be discussing subsequently in our HEMAT discussion. Having said that, I'll just take that opportunity to talk about the fact that as and when we are going to be talking about these kind of tests, and I'm making a mention of APTT and PT, what they love to ask you in the exam is going to be a simple fact that for the performance of these kind of tests, it is very important that you do not, and I repeat, do not take the sample in a glass syringe. Reason I explained you and has been asked in the exam earlier, glass is going to cause activation of the intrinsic pathway. So what the protocol talks about is that you are going to be using something like a plastic syringe. It is always better to perform the test as early as possible, preferably within 2 hours of collection of the blood sample, so that there is minimal alteration so far as the value of your patient is concerned. And the kind of an anticoagulant that is going to be used over here is 3.2% trisodium citrate. So those have been the questions which have been asked by the Amazonians earlier, and make sure that you do have an idea about that fact. I repeat the fact, please do not use a glass syringe for carrying out the coagulation test like PT and APTT. Now talking about chronic inflammation, which is the long duration inflammatory process, we just need to remember and differentiate the fact that this particular process is going to be characterized by the presence of a hallmark feature, which is going to be something like tissue destruction. Having said that, we need to be familiar with the fact that certain types of chronic inflammatory cells are going to be playing a very important role. Over here we have the role that is being played by macrophages in particular. In case of chronic inflammation, macrophages are likely to get activated. Before we talk about the activated state of the macrophages, I would like you to recall the important name of the macrophages present in different organs of the body. I'll just keep on drawing the organs and you just quickly have a recap. For liver, it is going to be a Kupffer cell. So far as the bone is concerned, that is an osteoclast. So far as the brain is concerned, that is going to be a microglia. Remember the fact, microglia, also known by the name of a Gitter cell. That is what they love to ask you in the exam. When we are talking about the macrophage, which is going to be present in the placental tissue, that is going to be given the name of a Hofbauer cell. Hofbauer cell. Of course, most of the people are intelligent enough to recall the name of a macrophage that is going to be present inside the kidney. That is going to be given the name of a mesangial cell. When we are talking about chronic inflammation, certain patterns of chronic inflammation are going to be associated with the formation of a granuloma. Say, for example, those conditions are going to be given the name of granulomatous inflammation. So we talk about something like tuberculosis, leprosy, we talk about something like Crohn's disease, we talk about certain types of vascular disorders when we're talking about the granulomas. When we are talking about granulomas, we also need to be familiar with the fact that certain types of granulomas are going to be specially asked in the exam because of the kind of picture that you get histologically. Though that's an easy one, but then you should not be making a mistake in these questions. So let us look at these granulomas one by one. The first example is what I would like to share with you. A guy who comes to your clinic because he's having the presence of weight loss, he's having cervical lymphadenopathy, he doesn't feel like eating anything, and his family member tells you that he is losing weight. That kind of a history in Indian context, fever, weight loss, presence of night sweats, he's having malaise, you first have to think in terms of something like tuberculosis. Now, when you look at that kind of an image, that might as well be giving a hint with regards to a granuloma that you get in case of tuberculosis. That is going to be an example of as you find a kind of a very pinkish kind of an appearance that is in fact representative of necrosis, and that is going to be given the name of a caseating granuloma. So caseating granuloma, I presume that in the higher magnification, some of you will be able to appreciate the fact you would be having the presence of giant cells over here, which are going to be given the name of Langerhans giant cell. I shall be showing you them separately as well. Second type of granuloma, in which the individuals are going to be having the presence of a history which is quite similar to the history of pulmonary tuberculosis, but when you take the biopsy and examine it microscopically, you find that it is characterized by fact number 1, non-caseating granuloma, and fact number 2, you find very minimal lymphocytic infiltration at the peripheral parts. When you have a very minimal lymphocytic infiltration, the term that you are using for that kind of a granuloma is a naked granuloma. The moment you are hearing a term naked granuloma, I want your eyes to shine up in the exam, because this is quite suggestive of the fact that your patient is suffering from a condition like sarcoidosis. So in sarcoidosis, as you may be able to appreciate over here, you do have the presence of epithelioid cells, you do have the presence of giant cells, but you hardly find any lymphocytic infiltration, or I would say it's a minimal lymphocytic infiltration that you get in case of sarcoidosis. So the term that is being used is a naked granuloma. The third one that you can appreciate over here is the one which is going to be having a zigzag kind of a pattern. So that would be reminding you of Twinkle Twinkle Little Star. That star shaped granuloma is what is going to be given the name of a stellate granuloma. Stellate means star shape. You can recall the fact this is typically seen in case of a patient suffering from cat scratch disease. The granulomatous inflammation is caused because of the organism Bartonella hensii. The fourth important pattern that I would like you to be familiar with over here is the one that I'm just trying to make a mention of over here. This is what you get over there, a donut shaped granuloma. A recent exam question. The donut granuloma is what you find in a patient. Make a donut and put a question mark over there, you get the answer. Q fever, Coxiella burnetii. So donut shaped granuloma is what you find in case of Coxiella burnetii. Infections. The next one that you have is an example of a perivascular granuloma. The one which is going to be caused because of the patient suffering from infection caused by a plasmodium, and what I'm referring to over here is the presence of cerebral malaria. Cerebral malaria. So when we are talking about something like cerebral malaria, you get perivascular granulomas, and the term that is being used for these granulomas, just a malaria question as well as an important image for the exam, Dirk granuloma. Dirk granuloma. So those are the examples of granulomas that you need to have an idea, which have been very frequently asked in the exam. Having a look at some of the important giant cells. I recall the fact for you that giant cells are going to be produced because of fusion of macrophages, courtesy the interferon gamma. These are going to be multinucleated cells, but the nuclear pattern in some of these giant cells is going to make them unique and special appearance. Although that is not something which is a 100% diagnostic thing for a pathologist, we definitely have better ways of confirming a diagnosis, but your examiners still love to give you those kind of images because they would act as vital hints for you to crack the question in the exam. So I always talk about that fact. The history that they give in the exam, the STEM history is given, there is certain keywords which are hidden over there. That is what will help you crack the question, and definitely some of the important images which are likely to be helping you in the exam as well. First important example of a giant cell, you find all the nuclei present in the periphery in a U-shaped pattern, or you can say a horseshoe pattern. So this would be U. Had it been an image which would have been inverted, you would have got an inverted U pattern. So this is what is going to be given the name of a Langerhans giant cell. Langerhans giant cell, classically that is what you associate in a patient suffering from tubercular infection. The second important one is the one in which you have a giant cell in which you are going to be having a collection which is in a haphazard fashion. So this is what is going to be given the name of a foreign body giant cell. Classically they will talk about a surgeon who was having some kind of a history of allergy to latex. He therefore performed a surgery using the gloves, and subsequently there was a granulomatous inflammation that he had on the skin, which could be associated with something like a foreign body giant cell, a giant cell in which you are going to be having presence of haphazard nuclear arrangement. A third important example of a giant cell can be the one, yes, you find the presence of a multinucleated cell, but then you can also appreciate the foam-like appearance over here. Foam-like appearance typically seen because of presence of intracellular lipids. And the moment you think about intracellular lipids, what should be striking your mind is going to be a condition which is given the name of xanthoma. The kind of giant cells that we are looking at as of now is going to be given the name of a Taunton giant cell. The fourth important pattern of a giant cell that we find over here is a multinucleated giant cell, the one which is going to be having the presence of viral inclusions. So classically unimmunized child history, having presence of fever, having the presence of a red color rash opposite the second molar tooth. You would think in terms of a child who is going to be suffering from measles. And the kind of a giant cell that you have over here is going to be given the name of Warthin-Finkelday giant cell. So either of the terms or the classical history with the mention of the term Koplik spot would be a giveaway. So that is what you need to be familiar with the fact. Warthin-Finkelday cell, a finding you associate with measles. We also need to be familiar with an example of the most often and the most loved giant cell for the exam. That's an example of a giant cell which is going to be having the presence of two nuclei, having the presence of a prominent nucleolus. Of course, we are talking about something like a Reed-Sternberg cell. This is going to be seen in a patient suffering from Hodgkin's lymphoma. So those are the important example of giant cells which are must to know giant cells so far as our exams are concerned. We then need to be just wrapping up the discussion by talking a couple of points with regards to wound healing. When you talk about wound healing, that is going to be characterized by the fact that you're going to be having the question asked in the exam as a hallmark for wound healing, that is going to be the deposition of granulation tissue. Having said that, once we are talking about the deposition of the granulation tissue, what we refer by granulation tissue would be that you would be having the presence of macrophages, you would be having blood vessels, and for sure you're going to be having the deposition of collagen. As and when we are making a mention of something like wound healing, we just need to understand the fact that wound healing can be having two important subtypes. So there is healing by primary intention and there is going to be healing by secondary intention. When you talk about the healing by primary intention, what you have over here is that there is going to be a deposition of collagen, and the question the exam would be asking you about neovascularization. You see, what I want you to remember over here is that initially and typically the day 3 is the time when you are going to be having the deposition of the granulation tissue. There are different subtypes of collagen that we understand. So if we just quickly recap about them, collagen type 1 is what is present in the bone, that's the most abundant collagen. Collagen type 2 is the one that is present in the cartilage. Collagen type 3 is what is going to be present at the time of wound healing, and collagen type 4 is the one which is going to be present in the basement membrane of different organs in the body. Commonly asked question in the exam would be with regards to the collagen subtype 4 present in the kidney as well as in the lungs. Having said that, when we are talking about the collagen over here, we just need to be familiar with the fact that initially we are going to be having the presence of a collagen which is going to be deposited, and the way by which you are going to be distinguishing the primary wound healing from the secondary wound healing would be that secondary wound healing is going to be characterized by the concept of wound contraction, which is also given on the question exam can talk about wound strength. Now, whenever we're going to be talking about collagen, I want you to be familiar with the fact that strength of the collagen is going to be dependent on the subtype of collagen. So initially what you're going to be having is you're going to be having the deposition of something which is going to be given the name of collagen type 3, and subsequently after about a month you're going to be having the collagen type 1 which is going to replace this. So initial deposition of collagen type 3 subsequently being replaced by collagen type 1. That is one way by which the examiners can be putting up that question to you. Please remember that takes place after 4 weeks. Now, please be also familiar with the fact that when we are talking about the concept of wound strength, there are different time zones at which the wound is going to be acquiring a strength. Fact number 1, whenever we are talking about secondary wound healing, it's a deeper kind of a wound. It is associated with more exuberant inflammatory response, and therefore you would be having formation of a scar. The question that they put up to in the exam, what is the reason for the scar formation, is because of a cell that is given the name of a myofibroblast. Myofibroblast has got a contractile property, thereby making the scar shrink in size over a period of time. We also need to be familiar with the fact, as I was making a mention of over here, that around at 1 week of wound healing, the strength of the newly formed wound is only 10% of the strength of the original tissue. However, what you observe is by the end of 3 months, and that is by the end of 12 weeks, the strength of the wound is going to become almost 70%. As has been asked so many times earlier, as more time passes by, strength of the wound is going to gradually increase. But please remember the fact, the strength of the wound is never ever going to reach 100%. So theoretically speaking, that is something which is of a relevance as to as and when more time passes by, the wound is going to become more strengthful. But we need to remember at least those two important timelines. After 7 days, 10% of the original strength, and after about 3 months, 70% of the strength of the wound is what is going to be present. Now, talking about the types of abnormal wound healing, we have an example of a condition where we have excessive amount of granulation tissue which is going to be getting deposited, what is going to be given the name of a proud flesh or an exuberant granulation tissue. The more common last question in the exam would be with regards to the differentiating features between a hypertrophic scar and a keloid. So just have a look at them quickly. Hypertrophic scar is not going to be associated with any kind of a genetic predisposition. That is going to be usually present at any site. When we are talking about hypertrophic scar, it is having a property, it may spontaneously have a reduction in its size. On the other hand, when we are talking about something like a keloid, it is having a genetic predisposition, more commonly seen in case of Africans, and it is going to be classically having the commonest site being sternum. Of course, it can be seen around the earlobe or the pinna, and we are going to be having no spontaneous regression in case of a keloid. very important from the perspective of a histopathologist would be the fact and the pathophysiological basis, hypertrophic scar is going to remain within the boundary. So as I always talk about that kind of a diagrammatic representation, let me say this was an example of a wound. Whenever we're going to be talking about the hypertrophic scar would be something like this. So it never ever grows beyond the boundaries. It grows vertically, but it doesn't grow vertically as well as horizontally. Whereas keloid has got that kind of a property, it is likely to overgrow the wound boundaries. Additionally, we need to be familiar with the fact at a microscopic level, what they haven't asked, but they may ask, is the fact hypertrophic scar is having the presence of collagen fibers which are arranged in a parallel fashion. Whereas in context of a keloid, there is going to be a haphazard arrangement of collagen. So that is what is going to make the discussion of the inflammation crisp and clear to most of you. Now I'm going to be having a discussion about and a quick recap about the immune system. Now as and when we are talking about the immune system, that's the defensive part of our body, and as we have talked about in the main video section as well, it has got two arms, the innate immunity and the adaptive immunity. We call the fact that innate immunity is an example of a non-specific arm of the immunity which is going to be contributed by the presence of skin, that means the epithelial barrier. We would be having the presence of certain types of cells like the phagocytic cells, the dendritic cells, the NK cells, as well as the complement proteins. There are certain important components of the innate immunity. Say for example, when we are talking about the lungs, we need to be familiar with the fact that surfactant is an important component of innate immunity. Similarly, if you are going to be talking about the cells, there is a special subset of the T cells which is going to be given the name of the delta gamma T cells, and these are the example of cells which are going to be present in the gut mucosa. They are also going to be an important component of innate immunity. Now, the reason I specifically make a mention of the gamma delta T cells is because of the fact that when you're looking at the adaptive immunity, this is a more specific arm of the immunity. It has got memory as well, which means that on a repeated exposure of an antigen, there is going to be mounting of a more powerful immune response. Adaptive immunity is going to be contributed by the B cells, which get activated in coming in contact with an antigen, get converted them into plasma cells, and are responsible for secretion of antibodies. Because the antibodies are present in the natural fluids in the body, so that is given the name of a humoral immunity. And as and when we are making a mention of the second arm of the adaptive immunity, that is contributed by the cellular component, which is going to be the T cells. So what I essentially wish to tell you over here is going to be a concept that T cells are predominantly going to be contributing to adaptive immunity, but there is a special subtype of T cells given the name of the gamma delta T cells, which are a component of innate immunity. Fact number 2, as and when we are making a mention of the complement proteins, the complement proteins can get activated, as we discussed in the section of inflammation. They can get activated without the presence of antibodies. Say for example, mannose binding lectin, that would be an example of innate immunity. But complement proteins are also going to be activated because of antibodies, and antibodies are coming from the plasma cells. So in a way, you can say the fact that complement proteins can be included both under the category of innate as well as adaptive immunity, though I would say that it is a kind of a very integral link or an important link between these two arms of the immunity. Now, we also need to be familiar with the fact that there is going to be important role played by certain different types of receptors, about which one of them was asked in the exam. One important receptor that I specifically wish to make a mention of over here for you friends is going to be given the name of a toll-like receptor. The toll-like receptor is important because when this receptor is going to get activated, this is going to be responsible for causing activation of nuclear factor kappa beta, and nuclear factor kappa beta is subsequently responsible for causing secretion of cytokines. An important situation what I would like you to be familiar with this is an example of a structure that we did make a mention of in our discussion of cell injury, wherein we did talk about the concept of pyroptosis, which I hope you remember in interleukin 1 and 11, inflammasome. So inflammasome is going to be an example of an important component that is going to be responsible for causing recognition of both microorganisms, and it is also responsible for causing recognition of dead cells. This inflammasome is important because the inflammasome is going to be getting activated, and now it is going to be associated with the release of interleukin 1. Exactly the kind of thing I was telling you about. Interleukin 1 and 11 going to play a very important role so far as the process of pyroptosis is concerned. So what you just need to be familiar with over here is, you were asked a question in the recent exams, which of the following is going to be responsible for recognition of dead cells, and the answer to the question happened to be just about something like inflammasome, right? Now, talking about the next important component over here, which is going to be the different types of cells which play a very important role in the activation of the immune system. Now, two important categories of cells about which salient features are commonly asked in the exam. One is going to be the presence of cells which are going to be given the name of the lymphocytes, and second would be the example of the antigen presenting cells. Now, we had a discussion about this particular fact, but nonetheless easy for us to recall the fact that this is going to be an example of an antigen presenting cell. It captures the antigen, present it to the T cell. We'll just talk about that again. We'll talk about this molecule that a lot of you recall happens to be the MHC molecule, and we'll talk about the properties of the T cell receptor as well. Now, talking about the lymphocytes, there are important categories of lymphocytes that we need to understand. First category of lymphocytes, which are going to be predominantly getting matured in the thymus gland, so they're going to be given the name of the T cells. Now, when we are talking about the T cells are going to contribute to almost like 60 to 70% of the cells that we are having in the peripheral blood. On the other hand, as and when we are making a mention of the T cells, we need to remind ourselves of certain important CD molecules like CD3, which is going to be given the name of a pan T cell marker. Another important molecule that we need to be familiar with regards to T cell is the co-stimulatory molecule, which is CD28. And as we understand, the co-stimulatory signals are very important, particularly when the antigen presenting cell is going to bring an external antigen, an exogenous antigen in contact with a T cell receptor. Now, there are different subtypes of the T cells about which we need to have an idea. Helper T cells, which are also given the name of the CD4 T cells. They are further divided into groups like helper T cell subtype 1 and helper T cell subtype 2. Helper T cell subtype 1 playing a very important role in type 4 hypersensitivity reaction. Helper T cell subtype 2 plays a very important role in the development of type 1 hypersensitivity reaction. And we have a special subtype of helper T cell that is given the name of TH17, responsible for the secretion of interleukin 17, as well as going to contribute to development of cold abscess and pretty important for fighting out fungal infections and certain autoimmune disorders. When we are talking about something like the CD8 T cells, they are also given the name of the cytotoxic T cells. Extremely important cells, particularly when we wish to talk about killing the virus infected cells as well as taking care of the mutated cells. So usually the cancer cells, the tumor cells and the virus infected cells are going to be taken care of by the cytotoxic cells. The next important thing that we need to have an idea over here is with regards to a special type of helper T cells, which are given the name of the T regulatory cells. Now, why those cells become important is because these cells are responsible for being anti-inflammatory in nature. So, T regulatory cells are going to be important because they are responsible for secretion of anti-inflammatory cytokines. And in fact, if you have watched that video of inflammation, either the main section videos or the RR videos, you would recall anti-inflammatory cytokines would include interleukin 10 and TGF beta. Don't look at your notes, just try to revise verbally what are the example of cytokines which are having a dual action. They can be pro-inflammatory at times, they can be anti-inflammatory at times. Yes, you're very right. You love cricket for that matter. Interleukin 4, interleukin 6. Talking about the next important thing, when we are talking about the anatomical questions asked with respect to T cells, T cells can be present in multiple areas of the body, so they can be present in the lymph nodes, and especially the part of the lymph node where they are going to be present is going to be given the name of the paracortical zone. When we are talking about the other locations that they can be present inside the GI tract epithelium, so they can be example of what is being termed as the intraepithelial lymphocytes. One important type of T cell that I specifically told you, friends, majority of the T cells are going to be having the receptor which is made up of alpha and beta unit. That is going to be a component of adaptive immunity. But when you're talking about gamma delta T cells, they are a component of innate immunity. They are present in the GI tract. The importance of knowing about the gamma delta T cells lies in the fact that they are going to be acting as a defense barrier so far as the innate immunity arm is concerned. The other important thing that we are asking the exam at times is location of the T cells with respect to something like the lymph nodes. So they are present in the periarteriolar lymphoid sheath. Talking about the second category of lymphocytes, these are going to be the B cells. The B cells, just like the T cells, are also having the presence of a pan B cell marker, which is going to be the CD19 molecule. When we are talking about the B cells, the important role lies in the fact that they are responsible for the production of antibodies. So B cells get converted into plasma cells, and plasma cells are responsible for secretion of antibodies. Different types of antibodies which most of us would be able to recall quite comfortably, remembered with the acronym GAMD. So IgG, present in maximum concentration, responsible for crossing the placental barrier, reaching out to the fetus, as well as responsible for causing activation of the classical pathway of the complement system. IgA, the first line of defense, present in the mucosal tissue, present in the secretions, and is therefore extremely important for fighting as I use the term first line of defense, a very important antibody which is going to protect our respiratory, GI and urinary tract mucosa. When you're talking about IgM, milliners antibody, big size, pentameric antibody, and it is the primary antibody which is going to be produced at the time of the immune response. So primary immune response antibody, IgM, a marker of acute infections, IgG, the marker of chronic infections, or usually produced at the time of a repeated immune response. When you're talking about IgD, that is going to be a component of the B cell receptor. When you're talking about IgE, that is going to be pretty important so far as a type 1 hypersensitivity reaction is concerned or elevated at the time of allergic reactions. Now, having said that, we need to be having an idea with regards to additional molecules about which we are asked questions in the exam, CD40. So CD40 molecule of the B cell would be interacting with the CD40 ligand present on the surface of a T cell, and that kind of an interaction becomes very important when you're talking about formation of one particular class of antibodies into other, which is given the name of class switching, or technically called by the name of isotype switching. If that kind of an interaction does not take place for any reason, the isotype switching will not be taking place, and that is classically what is seen in a patient who's going to be suffering from a condition given the name of hyper IgM syndrome. As a lot of you should be able to understand that fact, that was an exam question which was given to you in the form of a flow cytometry based point, wherein they talked about on the x-axis and the y-axis one of these molecules was depicted to be deficient. So watch out for that particular fact in the main section video, as well as when you are looking at the video of the previous years. The next important thing that we need to have an idea is the role that is being played by CD80 and CD86. CD80 is what is given the name of B7.1. CD86 given the name of B7.2, and these are the molecules which are going to be interacting with CD28 molecule. The reason why they become important is because this molecule is co-stimulatory in nature. So this is an example of a co-stimulatory signal which is given only and only when the antigen presenting cell comes in contact with a T cell, and when the antigen presenting cell actually carries an external antigen. Such co-stimulatory signals are absent when the antigen presenting cell by mistake is going to present a self antigen. I'll talk about that again, but as of now, I just want you to remember about this interaction, because one of the initial questions which was asked in the exam was, which of the following is not going to be involved in the process of a co-stimulatory signal generation? So the options asked in the exam were B7.1, B7.2, B7.3 and CD40. You need to understand the fact all these are important. Of course, B7.3 is not going to be involved in the process of co-stimulatory signal. Another important thing that we need to be familiar with is a third category of cells which are given the name of NK cells. Very, very important cells for the simple fact that NK cells are going to be an important line of defense whenever we are talking about virus infected cells, whenever we are talking about the cancer cells or the cells which are having some kind of a mutation. Now, NK cells are different from the other cells. I mean, the similar property of destruction of virus infected cells and the tumor cells is also seen in case of CD8 T cells, right? But why are NK cells going to be different is because NK cells are not dependent upon MHC molecules, in the sense that they are going to be MHC independent killing cells. So that's a keyword that you need to remember in the exam, and watch out for the difference in the language of the question. There's a very subtle difference, but very helpful for cracking a question. So if we are talking about a virus infected cell in which we find that there is an MHC dependent killing, definitely the answer is CD8 T cell. But if the question in the exam talk about MHC unrestricted, MHC independent killing, then the examiner wishes to ask you a question on NK cell. Now, NK cell has got multiple markers which are commonly asked in the exam. The classical markers of NK cell include CD16 and CD56. However, I must tell you over here that NK cell, just like other cells of the body, can be having presence of different types of molecule on its surface. One molecule can be a stimulatory molecule which will activate a NK cell. Another molecule can be an inhibitory molecule which is going to inactivate a NK cell. The example of an inhibitory molecule present or expressed on the surface of NK cell is what the examiners love to ask you. In fact, that was a recent INISET question as well, CD94. So CD94 is an example of an inhibitory molecule, and that is going to reduce the chances of activation of the NK cell. This becomes particularly important because CD94 is utilized by self antigens. So imagine a situation in the systemic circulation, NK cell comes in contact with any normal cell of the body. Now, you would not like to activate the NK cell over there. So, self antigens of the normal tissues are going to interact with CD94, thereby preventing an activation of the natural killer cell. So, that is the significance of knowing about the NK cell over here. Of course, we have used the term over here MHC unrestricted killing so far as the NK cells are concerned. Talking about the second important category of the immune cells, after discussion of the lymphocytes, we have got antigen presenting cells. And as I did talk about these particular cells with you friends, antigen presenting cells, the main function is they would phagocytose any externally coming antigen. They would process it into peptides, and those peptides are now going to be expressed on the surface with the help of a MHC molecule. So antigen presenting cells are having the presence of MHC expression. Now, whenever we are talking about the MHC expression on the surface of antigen presenting cells, we just understand MHC molecules can be of two different types, MHC1 and MHC2. if you have an antigen coming in contact with MHC1 molecule, this is likely to go and cause activation of the CD8 T cells. If you are having expression of MHC2 molecule which is coming in contact with the antigen, this would cause activation of the CD4 T cells. So we use the terms that CD4 T cells are MHC2 restricted cells, CD8 T cells are MHC1 restricted. In simple terms, you can remember they require the help of respective CD molecules in order to get activated, right? The second thing that we can use over here is that from our knowledge of physiology, we understand the fact that CD4 CD8 T cell ratio is going to be 2:1. So that simple ratio physiology question will also help you remember the fact if antigen binds to MHC1, it will go and activate CD8 T cell. If antigen binds to MHC2, it will go and activate the CD4 T cell. Now, when we talk about antigen presenting cells, we need to understand they can be either professional antigen presenting cells. Professional antigen presenting cells are those antigen presenting cells which have got a high expression of MHC molecule on their surface. But at the times of emergency, let's say for example a severe infection, you may require certain cells to behave as antigen presenting cells, but those cells are given the name of non-professional antigen presenting cells. Now, talking about the professional antigen presenting cells, we have cells like dendritic cells. One of the important example of the dendritic cells about which we need to have an idea is the normal cell present in your and my skin, which is given the name of a Langerhans cell. Watch out for that simple mistake in the exam. Langerhans cell in the exam is not to be confused with Langhans cell, which is the giant cell that you have in a patient suffering from tuberculosis. A second important example of a professional antigen presenting cell can be macrophages, and a third important example of antigen presenting cells of the professional subtype are the B cells. Now, these cells therefore are going to be having the expression of MHC molecule, as well as they are going to be having the presence of co-stimulatory molecules like the one we talked about earlier, CD80, CD86. When we are talking about the non-professional antigen presenting cell, this is what the AIMS people love to ask you as a question. We have the role which is being played by the skin fibroblast, we have the role played by the thymic epithelial cells, we have the role played by the glial cells in the brain, the pancreatic beta cells, in fact even the thyroid epithelial cells, and at times the vascular endothelial cells. So this category is relatively shorter for the one-liner questions, but as is the current trend for the INI-CET exam, wherein they might as well give you a list of 5 to 6 cells and then ask you to tick, or they ask it in the form of a true-false question. You need to be familiar with this list as well. Talking about the fact that when we are talking about MHC subtypes, MHC1 and MHC2, they are going to be having a slight variation in their structure, which can be appreciated with the help of this diagrammatic representation. So when you are looking closely on the diagram, you understand the fact the MHC1 is going to be having the peptide binding clef. That's a antigenic peptide binding clef which is being produced by alpha 1 and alpha 2 subunits. The alpha 1 and the alpha 2 subunits, as you can understand, are away from the cell membrane, so they are given the name of distal alpha units. So MHC1 is having the cleft which is made up of alpha 1 and alpha 2, and the peptide binding cleft is formed by the distal alpha chains. When we are talking about the MHC2 molecule, the MHC2 molecule is also having a antigenic peptide cleft, and this is made up of alpha 1 and beta 1 chains. So the examiners have asked you this kind of a question. They have asked you the difference between the antigen binding cleft being formed by which of the following subchains, alpha 1 and alpha 2 in case of MHC1, alpha 1 and beta 1 in case of MHC2. Not to forget the fact that MHC1 is going to be activating CD8 T cells, MHC2 is going to be activating CD4 T cells. Whenever we are going to be talking about the next important thing, that would be with regards to the fact how exactly the MHC molecule is going to help in the interaction between the antigen presenting cell as well as the T cell. Now looking at this particular diagram, which will help you facilitate your learning, this is the antigen presenting cell having the expression of MHC molecule, and this is going to be having the presence of an antigen expressed over here which will come in contact with the T cell receptor. The moment there is going to be an interaction between the MHC molecule, the antigenic peptide and the T cell receptor, it is responsible for a generation of signal 1. That's a first signal which is going to go to a T cell. But as I've told you with the respect of the car example story, which I presume all of you remember, that's just turning on the ignition, not putting the gear. So what will put the car into gear? That would be the second signal, that is signal 2. And the reason for that second signal is this is given the name of the co-stimulatory signal. So as mentioned earlier, and what you need to remember, CD28 is expressed on the surface of T cells, and B7.1, B7.2 expressed on the surface of APC. These would have an interaction, and then the second signal will go. So the car will be put into gear and the car moves. That means the T cell is going to get activated. So you require signal 1 as well as the co-stimulatory signal for activation of the T cell. Now this is exactly what is taking place at the time of the presentation of an external antigen. By some chance, let us say we have the presentation of a self antigen which is done by APC. In such a situation, what you find over here is that yes, there is a generation of signal 1. Of course, antigenic peptide has been presented, so signal 1 is going to be there. But in the case of self antigens, as you understand, there is going to be no co-stimulatory signal. No co-stimulatory signal. And because there is no co-stimulatory signal, the T cell cannot be activated. Because the T cell cannot be activated, so the T cell becomes non-functional. That's exactly what is given the name of T cell energy. It appears to you as if the T cell has zero energy, it is becoming inactive, it cannot be activated. So this is called as T cell energy, typically seen whenever there is going to be the presentation of a self antigen. Now this mechanism of T cell energy becomes very important, particularly when we are talking about a self antigen, and this particular mechanism is going to contribute to what is going to be given the name of self tolerance. So tolerance in immunity means a simple fact that on the presentation of a self antigen, you do not allow the immune cells to get activated. Why that becomes important is, God forbid, in some individuals, if there is a failure of this kind of a protective mechanism, that means the immune cell is going to get activated even with self antigen. And if the immune system or the immune cells are activated by self antigen, that would automatically result in higher risk or development of autoimmune disorders. So fundamentally you need to understand the fact, the breakdown of self-tolerance, that's a previous NEET question, breakdown of self-tolerance is going to be associated with an increased risk or development of autoimmune disorders. Now let us just look at the different mechanisms by which tolerance does take place in our body. Now talking about the two important arms of tolerance, we have got one which is given the name of a central tolerance mechanism, the example of a tolerance which is going to be seen usually in the thymus and the bone marrow, and the second one is the peripheral tolerance. A lot of questions which are typically asked in exams, particularly in the NEET PG as well as the INI CET from this particular topic, so we will paying more attention to this one. Now when we talk about central tolerance is going to be contributed because of the concept or the theory of negative selection. So if there is going to be by mistake any developing T cell or a B cell which comes in contact with a self antigen, it is going to get eliminated. This process of elimination is given the name of negative selection. The second mechanism by which central tolerance takes place is the concept of receptor editing. The important point to be remembered over here is that if there is a receptor which comes in contact with a self antigen, we would like to alter the shape of this receptor so that it no more comes in contact with a self antigen. When we talk about the concept of negative selection, that is applicable for both B as well as T cells. But when we are talking about the concept of receptor editing, this is applicable only and only for B cells. So this has been a previous exam question which has to be kept in mind. Additionally, we need to be familiar with the fact that as and when we are going to be talking about something like the negative selection in the B and T cells, this is dependent upon a gene which is given the name of AIRE gene, standing for the autoimmune regulatory gene. Easy for us to understand. Suppose there is an individual who has a malfunctioning of this kind of a gene, that would be associated with development of a problem which is going to be given the name of autoimmune polyendocrinopathy syndrome, about which I have explained to you about the subtypes type 1 and 2 in the section of endocrinology in the main videos. So as of now, I will just take less time. I want you to understand the fact negative selection takes place affecting both B and T cells, but receptor editing is applicable for only and only B cell. Fact number 2, for the central tolerance, we have a role played by the AIRE gene, and if there is a problem with the gene, that would be associated with a high risk of development of autoimmune polyendocrinopathy syndrome. Having a look at now the peripheral tolerance, when you talk about peripheral tolerance, that can be contributed by mechanisms like apoptosis, that means the programmed cell death. So if in the periphery you are having the presence of self-activated B and T cells, if by mistake the B and T cells are present in the circulation and they still come in contact with self antigens and try to get activated, they should be eliminated by the process of apoptosis. The second can be the special sites which are never going to get exposed to the immune system per se. These are given the name of sites having antigen sequestration. So these are also being given the second important name of immune privileged sites. Now, I told you in the main video section, and I bet most of you remember that. Yes, that's exactly what I wanted to remember. I bet you remember that, because brain, eye, and testicular tissue, particularly in the testicular tissue, the seminiferous tubules, particularly in the eye, I want you to remember about the retinal epithelium and the cornea, and in the brain, I want you to remember about the fact that there is going to be presence of areas which are going to be associated with immune privilege. That means the antigens in this area do not come in contact with the immune system regularly. Therefore, at the times of special situations, somebody suffers from a head injury, somebody suffers from a traumatic injury to the testicular tissue, somebody has a ophthalmic injury, then those antigens are going to get released. Then they get active, cause activation of the immune system, and therefore you have development of conditions like sympathetic orchitis, sympathetic ophthalmitis developing. The other important fact I wanted to be familiar with is an important role that is being played by the T regulatory cells. So I told you there are special subtype of helper T cells which are responsible for secretion of anti-inflammatory cytokines. Therefore, they are going to be responsible for contributing to peripheral tolerance. A fourth mechanism can be what is going to be given the name of A energy. And when I talked about energy, I did talk about the fact that there can be energy because of the presence or involvement of T cells. So if there is going to be a reduced expression of CD28, the co-stimulatory molecule present on T cell, then activation cannot take place, energy. Or there could be a situation when you are going to be having the role which is going to be because of the molecule on the B cell. On the B cell, you can be having the reduced expression of a molecule like CD40. So CD40 reduced expression, CD28 reduced expression can be contributing to the development of energy. That is what we need to be familiar with so far as the central and the peripheral tolerance is concerned. Now, if for some reason there is going to be a breakdown of this tolerance, if there is a failure of this tolerance, that can be possibly associated with development or what is going to be given the name of, or a high risk of development of autoimmune disorders. Now, one example I can share with you over here is specifically with regards to something like T regulatory cells, we are having important role being played by certain molecules. For example, CD25. CD25 is the interleukin 2 receptor molecule which is going to be an integral component of the regulatory cells. If there is a malfunctioning of the CD25, the individual is going to be suffering from a syndrome that is given the name or condition given the name of multiple sclerosis. Now, recent exam question which I presume most of you can answer correctly. Multiple sclerosis is associated as a demyelinating disorder. What is the cell responsible for the secretion or formation of myelin in the central nervous system? You get that right, oligodendrocyte. Whereas if the question would have talked about myelin formation in the peripheral nervous system, it would have been answered as the Schwann cell. The second important molecule which can be having a trouble over here can be what is given the name of the FOXP3. And if there is going to be a trouble at the FOXP3 level, you have a development of a syndrome which I explained you in the main video in detail, the IPEX syndrome. So there is an immune dysregulation, there is a polyendocrinopathy, and there is going to be a trouble in the patient. So CD25 with multiple sclerosis and FOXP3 with IPEX syndrome, that is what I would like you to be familiar with so far as the failure or a problem at the level of the peripheral tolerance is concerned. Additionally, the questions are asked to us in the exam pertaining to the different mechanisms, all the mechanisms which can contribute to the development of autoimmune disorders. Mechanism number one can be that there can be simply a loss of tolerance. And there can be so many reasons which I just now explained to you. The important thing I would like you to be familiar with over here is that the most important gene contributing to the loss of tolerance happens to be the PTPN22 gene. Very, very important gene. If you have watched the main videos, we talked about that gene multiple times in our discussion in endocrinology and elsewhere. So PTPN22 gene is going to be contributing to the development of autoimmune disorders. Fact number two, we can be having autoimmune disorders because of polyclonal B cell activation. One of the very important mechanisms, what happens is, say for example, somebody gets a viral infection or somebody gets a bacterial infection. Then there is going to be formation of a group of B cells which are going to get activated into plasma cells. Out of those group of plasma cells, one particular subgroup can be producing antibodies which are self-debilitating in nature, which are attacking the self tissue. So that is what is going to be given the name of polyclonal B cell activation. This becomes very important with respect to certain types of viral infections about which they have asked you in the exams. So viral infections by this mechanism can enhance the risk for development of autoimmune disorders. A third mechanism I can help you remember over here is what is given the name of molecular mimicry. When you talk about molecular mimicry, there is a similarity between the exposed antigen and the hidden antigen, and that is going to be responsible for causing the development of a trouble. Say for example, what we talked about in case of rheumatic heart disease. So there is a similarity between the streptococcal antigen and the glycoprotein of the cardiac tissue causing the trouble. We talk about the cryptic epitope, which was the hidden antigen part I was sharing with you, which I have described with you, both these conditions in association with rheumatic heart disease. And finally, if we talk about infections, definitely infections can increase the risk of development of autoimmune disorders. The reason can be because infections are associated with higher expression of co-stimulatory molecules, and that has been proposed to enhance the risk of activation of the immune cells against self-antigens. Now, with respect to all these mechanisms, questions have been asked in the exam, but specifically the questions have been asked in the exam with respect to something like Epstein-Barr virus as well as HIV contributing to development of autoimmune disorders, and that is contributed because of the polyclonal B cell activation. So those are the different mechanisms by which the autoimmune disorders can take place, and of course I would highly recommend you to go through the section of the specific autoimmune disorders as well as SLE, because a lot of questions have been asked in the exam, particularly with respect to disorders like systemic sclerosis. They've asked you the question on something like dermatomyositis with regards to the antibodies with respect to the Gottron papules with respect to the heliotropic rash. So those are the things that you must have a look at, and we are going to be proceeding further to the next thing. Talking about the other important points with regards to MHC1 and MHC2, I just want you to be familiar with the fact that MHC1 is going to be expressed on the surface of all nucleated cells in the body, whereas MHC2 is going to be expressed on the surface of primarily all the antigen presenting cells, the professional antigen presenting cells as well as the non-professional antigen presenting cells. So far as the MHC1 is concerned, we need to be familiar with the fact that MHC1 is going to be associated with the fact that this can be present on certain non-nucleated cells as well. And when you're talking about the expression of MHC1 on the non-nucleated cells, you need to be familiar with the fact that it is going to be expressed on the surface of platelets, which reminds us of a very important fact that RBCs are not going to be having the expression of MHC1. MHC1 is also going to be having an important property that it can be identified with the help of what is going to be given the name of LO antisera. In contrast, if we were to make a mention of the MHC2 molecule, apart from the fact that the antigen binding cleft is made up of alpha 1 and beta 1, apart from the fact it is responsible for causing activation of the CD4 T cells, we need to be familiar with the fact that MHC2 is going to be responsible for the identification with the help of MLR, that is the mixed lymphocytic reaction. Now, the importance of knowing about MHC1 and MHC2 is also going to be with respect to the fact that if you remember about MHC, MHC is also going to be given the name of HLA. The set of genes is going to be present on short arm of chromosome 6, that is 6p, and if you remember the diagrammatic representation, it is something of this sort. So it is almost like 1, 3 and 2. So we have talked about something like MHC1, we did talk about something like MHC2, but we have not talked about MHC3. MHC3 is going to be coding for certain types of complement proteins, particularly early complement proteins, as well as certain enzymes like 25-alpha hydroxylase. So that is the importance of knowing about the MHC3 that we need to have an idea, and therefore the problem with MHC3 can be associated with a higher risk for development of something like SLE. Having said that, we need to be familiar with the fact that MHC molecules are important because not only they help us in our better understanding and correlating the pathogenesis of autoimmune disorders with certain types of genes or HLA, it is also important for establishing the paternity, and third important use can be having an establishment of some of these important genes with regards to the presence of carrying out a procedure which is going to be given the name of transplantation. The moment you are using the term transplantation, you should be familiarizing yourself with this kind of a diagram which is telling you about the difference between the different types of donors that we are going to be having. So transplant is also going to be given the name of a graft, and as and when the question the exam is asking you about the donor, we can understand the fact if an individual happens to be a donor for self, say for example in case of a skin graft, then that is what is going to be given the name of an autograft. If there is going to be an individual who's getting the graft from an individual of the same species, that means one human to the other and they are not related directly, then that is going to be given the name of an allograft. If an individual is going to be getting the graft from his identical twin, that is going to be given the name of an isograft. Iso refers to similar, same. So identical twins are going to be having the same set of genes, therefore isograft. And easy for us to remember, I for identical twin. And if we are going to be getting the graft from somebody from outside the species, somebody from a different species, say for example nowadays we are talking about getting the grafts from the animals. So if you are talking about that kind of a situation, it is going to be given the name of a xenograft. Chances of graft acceptance are going to be higher if there is going to be a similarity in the genes. So the best graft obviously is going to be an autograft, but then the conditions are going to be limited. Say for example, we are talking about a renal transplant individual. The ideal graft should be taken from somebody like an identical twin if available, and if, as we understand in the real world, everybody is not going to be lucky enough to have an identical twin for that matter. So we are going to be taking it from the individual from the same species. So we are going to be indulging in an allo transplant. Now, when we are carrying out an allograft transplantation, for example, in case of liver, for example, in case of kidney, I want you to understand the fact that the genes have to match, and with respect to the genes, the MHC matching or the MHC typing is being done. One of the most important genes which is to be ensured, which has to match over here, happens to be between the donor and the acceptor, is going to be HLA-DR. Of course, the more the set of haplotypes, the more the set of genes match, the better is the acceptability of the graft. But then this is the most important one, that as a doctor you must always remember. Every doctor carrying out a transplant or working in a transplant unit must remember that HLA-DR should match for a successful transplantation. The other important thing that we can talk about over here is going to be the fact that we can be having at times the development of transplant rejection. Out of them, the most important ones that they typically ask in the exam happens to be the hyperacute transplant rejection. Hyperacute transplant rejection takes place immediately, so within a span of few minutes to hours, and this particular transplant is going to be seen because of the fact that there is a type 2 hypersensitivity reaction. Now that is usually caused because of the presence of already formed antibodies. So all those words are important for you to highlight and be familiar with from the perspective of a question asked in the exam. They may ask you a question in the exam talking about acute transplant rejection, which is going to take place over a span of few weeks to months, and that is significantly contributed by cellular process. So that is going to be type 4. Of course, we have more evidence coming in the favor of the role played by antibodies as well, but then as the table makes a mention, more significantly type 4, we do have the role that is going to be played by the chronic graft rejection taking place after many months to years, and that is going to be having the role that is being played by the hypersensitivity type 3 and 4. But my recommendation to you would be at least be familiar with the hyperacute transplant rejection contributed by the antibodies and an example of a type 2 hypersensitivity. Now, when we are talking about a transplant rejection, this is the receptor, this is going to attack the graft. So just diagrammatic representation of, let us say this is the host, and this host is going to be attacking the transplant or the graft. So this is given the name of transplant rejection. It may so happen that the transplanted organ or the transplanted graft tissue is more strong so far as the immunity is concerned, and this starts attacking the host. If the transplant starts attacking the host, it is given the name of the graft versus host disease, and this graft versus host disease would be an example of a condition. If it takes place within 100 days, it is given the name of acute graft versus host disease. If that takes place after 100 days, that is called by the name of a chronic graft versus host disease. And typically in this kind of a condition, the tissues which are going to be affected are the skin, we get the involvement of the liver, and we get the involvement of the bone marrow. So we need to understand the fact that the initial manifestation of a graft versus host disease would be the development or appearance of a skin rash. Of course, the patients could be having the development of something like hepatic involvement in the form of development of a jaundice, or the individuals could be having the development of something like the bone marrow as well. Now, talking about the graft versus host disease, in which you are going to be getting the immunocompetent cells attacking the host, we understand the fact that this is classically going to be seen in case of a situation where you carry out something like a bone marrow transplant. Now, if this kind of an attack takes place within less than 100 days, then that is going to be given the name of acute graft versus host disease. If that kind of an attack takes place after 100 days, after about 3 months, it is given the name of chronic graft versus host disease. The organs which are going to be affected in case of graft versus host disease would be including the skin. That's the earliest organ which is going to get affected. So clinical manifestation would be in the form of development of a skin rash. Patients are likely to be having involvement of the liver. They can be having a development of a jaundice, or in chronic graft versus host disease, they can even be having the presence of fibrosis. And then there is an involvement of the intestine as well, which is classically manifested in the form of development of a diarrhea. So the moment you are hearing about something like graft versus host disease, the timeline is important. You need to be familiar with the tissues affected. You need to be familiar with the commonest transplant of the graft which can be possibly associated with development of this kind of a condition. From the perspective of previous exam questions, you need to be familiar with the fact that if we are talking about graft versus host disease, its animal counterpart is given the name of runt disease. The moment we are talking about something like acute transplant rejection, as I have told you, there is a role played by antibodies, and these antibodies are going to cause activation of the complement system. So you need to remember deposition of C4D. Deposition of C4D is one of the important markers for acute humoral rejection. You see, antibodies are involved, so that would be a component of humoral immunity. So C4D deposition is going to be seen as a marker for acute humoral rejection. Of course, they would be more than happy to ask you questions with regards to the timelines say for example less than 100 days, more than 100 days for runt disease or GVHD, or they would be asking question, a patient had undergone a kidney transplant and let us say by 5th month, at the end of 5 months he had suffered from a rejection. So what kind of rejection would that be? That would be acute rejection. So all those kind of timelines have to be remembered, and that's the way the questions are going to be given to you in the exams. Now making just a passing reference to the different subtypes of hypersensitivity reactions and the salient features, type 1 hypersensitivity reaction is important because that is going to be associated with an important role that is being played by IgE antibody. So far as the type 1 hypersensitivity reaction is concerned, we need to understand the fact that this condition is going to be having the role played by the helper T cell subtype 2. There would be secretion of cytokines like interleukin 4 and interleukin 5 is responsible for the secretion of more amount of IgE antibody and more amount of availability of eosinophils. That Ig antibody will attach itself on the surface of the mast cell. During a subsequent exposure, a repeat exposure, the antigen antibody reaction takes place on the surface of the mast cell, thereby causing an activation and degranulation of the mast cell. We can quickly brush up the fact that type 1 hypersensitivity reaction conditions can be remembered with A, B, C, D. So we can be talking about something like atopy, we can be talking about bronchial asthma, Cassoni's test, and we can be talking about drugs which can be responsible for type 1 hypersensitivity, classically the most notorious one being penicillin. Of course, previous exam questions have asked you about the reactions like the PK reaction or the Theobald-Schmidt phenomena, which can be associated with type 1 hypersensitivity. Type 2 hypersensitivity reaction is going to be when there is going to be attachment of the antigen with respect to a tissue and antibodies would be interfering with the function. So that is going to be the antibodies like IgG and IgM, and that is an example of a condition which can be remembered easily with the acronym that I made it so popular by this point of time. My blood group is RS positive, myasthenia gravis. B for remember the fact, blood transfusion reaction. G for remember the fact, Graves disease in good pastures. I for immune hemolytic anemia and immune thrombocytopenia. RS for RH incompatibility that you find, as well as for rheumatic fever. And then you talk about pernicious anemia as well as pemphigus vulgaris. When you're talking about type 3, there is formation of immune complexes. Usually there is going to be a time gap between the exposure of the antigen and the development of clinical manifestations. Usually areas which are going to be having a hyperfiltration of some kind of fluid, be it the glomeruli, be it at the level of the serosal surfaces, the joints, the skin, the small vessels are going to be involved so far as type 3 hypersensitivity reaction is concerned. So type 1 is given the name of immediate hypersensitivity, type 2 is given the name of cytolytic, type 3 immune complex disease, and that can be remembered with the acronym SHARP. The examples which a lot of you should be able to recall by this point of time: SLE, Schick test. We talk about serum sickness. We talk about condition which is going to be given the name of the Hinox-Schonlein purpura. We talk about Arthur's reaction, recent exam question as well. Raji's essay, post streptococcal glomerulonephritis, and we talk about polyarthritis nodosa. Finally, we talk about the type 4 hypersensitivity. Cells play a role, not the antibodies. So cell mediated hypersensitivity. Pretty important because we are going to be having the role that is going to be played by helper T cells subtype 1. Examples can include conditions which are going to be all associated with granuloma formation. Say for example, the tuberculin test, the lepromin test. We can talk about different types of vasculitis disorders, temporal arthritis, Takayasu arthritis. We can talk about contact dermatitis. We can be talking about an example of a condition. The subtype of type 4 that we need to remember can be having the role that is being played by CD8 T cell activation as well, wherein we did talk about the perforin granzyme mechanism, wherein we talk about the mechanism by which apoptosis can be induced inside the target cells, and that can be seen in association with destruction of the virus infected cells, that can be the destruction of the tumor cells as well. So all those are examples of conditions, and of course we can be talking about the transplant rejection over here as well, but then all those are examples of type 4 hypersensitivity. So basically an easy thing, but at the same time overconfidence should not be acting as an obstruction or a barrier for you getting these kind of questions incorrect in the exam. Talking about the important topic of amyloidosis, which is an all-time favorite for the examiners, and you need to kind of have a very good look at this table so that you are able to answer the questions pertaining to the classification of amyloidosis into the systemic and the localized category. Then you should be able to talk about the examples of the different kind of conditions which would be associated with different subtypes of amyloidosis. So in the INI-SET exam, what they did was they gave you a true-false kind of a question, and you were supposed to talk about whether the particular statement with respect to amyloidosis was true or false. So those kind of questions can be cracked only if you have an in-depth understanding about this kind of a table, however easy that may seem to be. But then, as I said just 2 minutes back, please do not let overconfidence get you a worse rank in the exam. So talking about that particular fact with a different mindset, primary amyloidosis, the example would include plasma cell dyscrasia, one of the commonest reasons for development of amyloidosis in the Western countries. The type of amyloidosis that you get over here is AL type, and that is primarily because of deposition of the lambda light chain. When you're talking about secondary amyloidosis, that is also given the name of reactive amyloidosis because of chronic inflammation, because of couple of tumors. You can be having that, say for example Hodgkin's and renal cell carcinoma, and you can be having the chemical nature of the amyloid as AA. We need to be familiar with a special type of reactive amyloidosis, which is going to be given the name of the familial Mediterranean fever, in which pyrin is an important protein playing a role in the development of the fever, and the nature of the amyloid over here therefore happens to be AA. That is going to be having a relatively good response with administration of a drug like colchicine. We need to be familiar with hemodialysis associated amyloidosis, typically seen in a patient suffering from a condition like CKD, the newer name for chronic renal failure, and the nature of amyloid happens to be A beta 2M, classically characterized by the fact that there is going to be a patient having a development of something like carpal tunnel syndrome, or maybe a problem at the knee joint level because of the fact that he has undergone a dialysis and there has been an accumulation of the beta 2 glycoprotein gradually over a period of time in the joints. When we talk about the hereditary polyneuropathies, we can be having the role of abnormal transthyretin protein, which is going to be doing the trouble over here. Of course, we can be having a condition in which there is a deposition of transthyretin, which is normal in nature as well. But that kind of a condition is what is going to be given the name of a senile cardiac amyloidosis or senile systemic amyloidosis, characterized by involvement of the cardiac tissue. So if you are having a normal transthyretin, suggestive of senile cardiac amyloidosis. If you have an abnormal transthyretin, suggestive of a familial amyloidotic polyneuropathy. The moment we are talking about an example of a condition, say for example, if you are talking about something like Alzheimer's disease or senile cerebral amyloidosis, it's a localized amyloidosis just like senile cardiac amyloidosis, that would be associated with the deposition of amyloid beta protein. And of course, as we understand, Alzheimer's is an example of the commonest cause of memory loss. When we talk about endocrine variants, we need to be familiar with the special subtype of thyroid cancer, which is medullary thyroid cancer, associated with the chemical nature of the amyloid as ACAL. When you're talking about type 2 diabetes, that is going to be the subtype of diabetes which is having amyloid deposition. So that is going to be having the development of deposition of amyloid protein given the name of AIAPP, that is islet associated pancreatic polypeptide. So we need to have an idea about this. Of course, when you talk about the different subtypes of organ involvement, we do get the role which is amyloid deposition in the kidney, which is going to be incidentally the most commonly and the most severely affected organ. If we talk about something like cardiac amyloidosis, very important cause of development of death in the patient suffering from the primary amyloidosis, as well as patients who are going to be having the senile cardiac amyloidosis, because that could result in development of an electrical arrhythmia. Cardiac involvement is also going to be associated with development of restrictive cardiomyopathy. So that's another important high point to remember. If amyloid is going to get deposited in the liver, that is going to be responsible for causing involvement of space of Deci. I mean, in contrast to something like kidney, where it is going to get initially deposited in the mesangium. In the liver, it is the space of Deci, and that would be responsible for causing development of hepatomegaly. So far as the splenic tissue is concerned, if there is an involvement of the red pulp, you give it the name of lardaceous spleen. If there is involvement of the white pulp, you call it by the name of a sago spleen, right? So the tapioca millet-like appearance that you get in the splenic tissue, which is enlarged, is what is being given the name of a sago spleen. The moment we are going to be talking about the example of the appearance of amyloid, so far as the histopathological examination is concerned, we need to be familiar with the commonest stain that is being used, which is Congo red. In Congo red examination, we are going to be having the presence of amyloid, which is going to be something like this. So you're going to be having a pink red appearance of the amyloid. Over here, you get that amyloid being deposited in the renal tissue. But in order to confirm whether it is actually amyloid or not, because this can be an example of some other material as well, what we are going to be using over here is going to be the example of Congo red followed by a different type of a light, which is going to be the polarized light, and that polarized light will confirm that you are having the presence of the characteristic apple green birefringence. Now, why exactly would amyloid be associated with apple green birefringence lies in the fact that this amyloid protein is actually made up of non-branching fibrils. So amyloid is going to be composed of 7.5 to 10 nanometers non-branching fibrils, and that is going to contribute to the presence of this kind of a shiny appearance. Of course, we understand the fact that there is going to be the presence of the beta plated structure of amyloid as well, which can be appreciated with the spectroscopy. As and when we are going to be looking at amyloid under the electron microscopy, That is what is going to be showing you the non-branching fibrils. Now, apart from Congo red, other stains which can be used possibly can be the PAS stains, and we can be using special stains for secondary immunofluorescence like thioflavin T, thioflavin S. Point to be remembered again that silver stains are not going to be helping us picking up amyloid. That's an important thing that we need to be having an idea. So different type of stains which we have talked about so very commonly at multiple places, as well as the kind of table that I showed you is most likely to help you crack almost all questions that they put up to you in the exams pertaining to amyloidosis. That takes care of a discussion of immunity. We're going to be talking about the most important features with respect to the quick revision of the topic of neoplasia. Now, as in when we are talking about the term neoplasia, neoplasia would refer to the fact that there is a presence of an uncontrolled proliferating stimulus for the cell, and in spite of removal of that kind of a stimulus, the cell still continues to proliferate. Now we understand the fact that in a normal cell there is going to be a limit beyond which the cells will stop replicating. That is what is being known by the name of Hayflick's limit. But two important exceptions to the Hayflick's limit that you must remember over here. Fact number one, when we are talking about stem cells, and fact number two, when we are talking about tumor cells. Having said that, we just need to be familiar with the salient features associated with the neoplasias. So four important features of a neoplasia that we always talk about, whether we are talking about a benign tumor or whether we are talking about a malignant tumor. The concept that you need to remember is that irrespective of the nature of the tumor, neoplasia per se would refer to the fact that the tumor happens to be having a monoclonal origin, and the monoclonality of the tumor can be assessed with the two isoforms of the enzyme G6PD-A and G6PD-B. So when we are talking about the features of neoplasia, the first important feature of neoplasia happens to be anaplasia. We then talk about the rapid rate of growth. We then have a look at invasion, and finally we talk about metastasis. Now out of them, as has been highlighted, anaplasia happens to be the hallmark feature of malignant transformation, and anaplasia simply refers to the fact that there is going to be a complete loss of differentiation of these cells. So as we talked about earlier, what we are going to be having in case of anaplasia is going to be the nuclear cytoplasmic ratio is going to become 1:1. There is going to be a loss of polarity. There is going to be presence of abnormal mitotic figures as well. Sometimes there is going to be presence of tripolar, or at times you would be having even the presence of quadripolar mitotic figures. That is what is likely to be suggestive of anaplasia. Anaplasia would be an example of a change which, strictly speaking, is an example of an irreversible change. Why do I make a mention of that particular fact is only because of the simple reason that when we are talking about a term like metaplasia, then we need to remember the fact that metaplasia is going to be an example of a reversible change, as we discussed earlier. Commonest example of metaplasia I would like you to recall over here: epithelial metaplasia. The commonest example happens to be the squamous metaplasia in the lungs of smokers. When we are talking about connective tissue metaplasia, we need to be reminding ourselves of something like the myositis ossificans. You got a question in the exam in the recent NEET PG which talked about dysplasia. Dysplasia is an example of a condition which is partially reversible. So in the initial stages, if you are going to be removing the noxious stimulus, the epithelial cells can still come back to the normal appearance. But if the stimulus is going to persist, then that gradually transforms into an anaplastic change. Whenever we are going to be talking about rate of growth, the rate of growth over here is going to be associated with the fact that there is going to be presence of a rapid rate of growth so far as the tumor cells is concerned. And then we need to be familiar with the fact that if there is going to be the number of tumor cells going to be 10 to the power of 9 cells, the tumor is going to be having a weight of roughly 1 grams. However, if the number of tumor cells is going to be 10 to the power of 12 cells, then we are going to be having a weight which is going to be 1 kg, which is the maximum compatible weight of a tumor with respect to life. So maximum weight of a tumor compatible with life happens to be something like 1 kg. As and when we are making a reference to something like rate of growth, we should be remembering and revising about the concept of Warburg effect. Warburg effect is what is going to be given the other important name of aerobic glycolysis. That's an example of a process by which, even though the cancer cells would be having exposure to sufficient amount of oxygen, still they are going to be consuming glucose by the process of glycolysis, and subsequently the metabolites are going to be useful for production of growth factors required for the proliferation of the tumor cells. Now this aerobic glycolysis is a concept that is going to be utilized as and when we are carrying out something like the PET scan, in which we are going to be utilizing a non-metabolizable, I repeat that, non-metabolizable form of glucose, which is going to be given the name of 18-fluorodeoxyglucose. When we are talking about invasion happens to be the fact that this is going to be the second most reliable feature of malignancy. That is what we need to have an idea. Invasion is also going to be important because that is helping in distinguishing between these two terms, and we did make a mention of the fact carcinoma and carcinoma in situ. In case of carcinoma, you are going to be getting invasion of the basement membrane. In case of carcinoma in situ, the basement membrane is unaffected, it is going to remain intact. When we are talking about metastasis, metastasis is going to be given the name of the most reliable feature of malignancy. Most reliable feature of malignancy, that is what we need to have an idea. Whenever we are going to be talking about the ways by which a tumor cell can metastasize, we can be having the presence of hematogenous spread, or we could be having the presence of something like a lymphatic spread, or we can be talking about the spread through the body cavities. We do have special modes of spread of the tumor, something like cerebrospinal fluid as well. Now, majority of the malignant tumors are going to be having the presence of metastasis in them, but there are few exceptions, and that exception was asked in the recent exam as well. So we have one important exception by the name of basal cell carcinoma of the skin. It is a malignant tumor, but still it is not going to be demonstrating metastasis. Second important example of a tumor is a brain tumor, which is going to be given the name of glioma, and that is again an example of a non-metastatic malignant tumor. Having said that, talking about the lymphatics, lymphatics are going to be the commonest ways by which the carcinomas or the epithelial malignant tumors are going to be having metastasis. That is what we need to remember. When we are talking about something like the hematogenous spread, it is found that more commonly the cancers are going to be spreading to the veins in comparison to the arteries, because logically the veins are going to be having a thinner wall in comparison to the arteries. This is typically true in case of a tumor which is going to be given the name of sarcoma. However, few exceptions that we need to remember over here, especially we need to be familiar with the exception that is going to be given the name of alveolar rhabdomyosarcoma, as well as we need to be familiar with an exception as synovial sarcoma. Even though they are example of sarcomas, but they are going to be having a spread more commonly involving the lymphatics. Similarly, if you are talking about the renal cell carcinoma and if you are talking about the hepatocellular carcinoma, even though the term used is carcinoma, but they are going to be notorious because they are going to be using the hematogenous mode of metastasis. So the two exceptions of carcinomas to be remembered, the two exceptions of sarcomas to be remembered from the perspective of questions asked in the exam. When you're talking about body cavities, it is the abdominal tumors or the tumors affecting the peritoneal cavity which are going to be involved over here. So the peritoneal cavity is the commonest body cavity to be affected. When we are talking about the cerebrospinal fluid, the important example of a tumor which the examiners love to give you time and again is a tumor that I have discussed separately in detail, medulloblastoma. It's a malignant tumor which is going to be seen in case of children, going to be rising from the cerebellum, and because it is going to be causing the metastasis using the cerebrospinal fluid, so we would be using a term with this kind of a tumor that is given the name of drop metastasis. Now, whenever there is going to be a spread of the tumor, sometimes what is going to be asked by you in the exam by the examiners is going to be a situation as we have talked about in our discussion of the systemic videos, wherein let us say we are talking about a patient who is going to be suffering from a gastric carcinoma, and let us say the patient is having a presence of a, let's say, male patient having a testicular malignancy or an individual having abdominal cancer. He could be having the enlargement of the left sided supraclavicular lymph node, so that is what is going to be given the name of Troisier sign. The enlargement of the lymph node is going to be given the name of the Virchow's lymph node. Patient having gastric cancer who is going to be having the enlargement of the left sided axillary lymph node, this is going to be given a separate name. So the one that we are using over here is Virchow's lymph node. This one is going to be given the name that is to be remembered and answered in the exam as this would be something like the iris lymph node. There is a possibility patients could be having the presence of deposits around the skin in the periumbilical area. This is what is going to be given the name of Sister Mary Joseph nodule. In fact, some of these patients could even be having the tumor deposits which are going to be present in the peritoneal shelf, so that is given the name of the Bloomer shelf. So Virchow's lymph node, iris lymph node, the presence of the Sister Mary Joseph nodule, Bloomer shelf, all those are terms which are going to be associated with the involvement of the lymph nodes. Now, important fact that we need to remember and revise over here is the fact that sometimes the first group of lymph nodes which is going to be affected, and I talked about this with the example of the commonest tumor that we have in case of females in our country, that is breast cancer. The first group of lymph nodes which is going to be affected is what is going to be given the name of sentinel lymph node. So sentinel lymph node, which is detected with the help of the tracer dye technique. That's another important question which was asked in the exam. So with respect to the cancer like the breast cancer, which is commonly seen in case of the upper outer quadrant, we are going to be having the axillary lymph nodes which are going to be behaving as the sentinel lymph nodes, which is going to be important to determine the extent of surgery as well as in determining the prognosis of the patient. So those are the additional things that we need to have an idea. Of course, if you are asked a question in the exam in which they are talking about the presence of a full peritoneal cavity involvement, which is going to be having the presence of something like the mucinous fluid, you would be thinking in terms of an example of a tumor which is going to be associated with the term pseudomyxoma peritonei. Pseudomyxoma peritonei. The moment we are talking about something like pseudomyxoma peritonei, we could be talking about an example of an appendiceal tumor, or we can be associating this in case of a female with something like an ovarian carcinoma. So those are the important things that we need to have an idea so far as the different types of features are concerned. Now, talking about some of the important terms which are commonly asked in the exams when you're talking about choristoma. Choristoma is given the name of ectopic rest of normal tissue. So when you are going to be having the presence of a normal tissue which is going to be present at an abnormal site, normal tissue present at abnormal site, that is an ectopic site, that is given the name of a choristoma. When you're talking about hamartoma, hamartoma is an abnormally differentiated tissue, but that is going to be present at the normal site. Commonest example of a hamartoma which is asked in your exam happens to be pulmonary hamartoma, and you read it the same particular condition in context of radiology as well, because it is going to be associated with the name the popcorn calcification. Again, a recent exam question. Talking about desmoplasia, normally we can be having a situation in which tumor cells are responsible for secretion of certain factors which are responsible for increasing the amount of connective tissue, say for example the collagen or the fibrous tissue, in which therefore you are going to be having a thickening of the connective tissue and the affected area. That is what is going to be given the name of desmoplasia. And the moment we are talking about something like teratoma, this would be reminding you of the example of this kind of an image. Teratoma is an example of a tumorous growth which is going to be arising from more than one germ cell layer. Therefore, you're going to be having the appearance in case of teratoma suggestive of the presence of an endodermal, the mesodermal and the ectodermal origin. You can appreciate over here the presence of something like a tooth-like structure. There can be presence of a glistening fat. You can be having the presence of something like a cartilage. There can be presence of hair. There can be presence of nails. There can be presence of skin as well. So primarily what that would tell you in essence would be that there is an origin from more than one germ cell layer. Now the point over here is that teratoma in case of males usually happens to be malignant. Whereas if a teratoma is going to be seen in case of a female, that is going to be an example of a benign teratoma, which reminds us of the fact that teratoma is going to be arising. The commonest site happens to be the gonadal cells. And if they are asking you the most common extragonadal site of a teratoma, that is to be answered in the exam as mediastinum. When we are talking about teratoma, sometimes a teratoma could be having the presence of, let us say, a skin tissue. And if there is a malignant transformation in the skin tissue, that is going to be typically an example of a squamous cell carcinoma. So those are the important terms with respect to something like teratoma and with respect to something like choristoma, hamartoma, desmoplasia that we need to be aware of. Now with respect to desmoplasia, the questions in the exam can be with respect to the stomach cancer, or they can be asking a question on something like the breast cancer. With respect to stomach cancer, you would be having an appearance of the stomach which is going to be given the name of leather bottle appearance of stomach. Leather bottle appearance of stomach. Also in Latin that is given the name of linitis plastica, for which an image has been discussed with you in the main video section, and I've talked about that particular image with you in the RR section in GIT as well. So make sure that you are familiar with the appearance of a linitis plastica. That's what we need to be familiar with so far as these terms is concerned. Now talking about the important concept with regards to the cell cycle and its regulation, we just need to remind ourselves of the fact that the cell cycle is going to be having multiple phases. The resting phase, which is given the name of the G0 phase. We then have the G1 phase, the S phase, the G2 phase and the M phase. Now they have asked you the questions. S phase is going to be the synthetic phase in which there is going to be a doubling of the nuclear material. Whenever we are talking about the cell cycle, we need to be aware about the two checkpoints that we are having. One is the G1S checkpoint and the second is the G2M checkpoint. The G1S checkpoint is under the regulatory control of two types of genes, one which is given the name of the RB gene, that is appreciated over here, and it is also going to be under the influence of the P53 gene. Whereas the G2 checkpoint, the second checkpoint that we have is that is at the level of the G2M, that is under the regulatory influence of P53. So essentially we can understand that the first checkpoint, which is over here G1S, as well as the G2M checkpoint, both of them are going to be controlled by the P53. However, when we are talking about the isolated gene which is going to be controlling the G1S checkpoint, you would answer it in the exam as RB. And when we are talking about the gene which is going to be controlling both the checkpoints, you would answer it in the exam as the P53. Now in a normal cell, what we are having is the presence of different types of molecules which are going to be present, which are given the name of cyclin dependent kinases. But these cyclin dependent kinases can be activated only by cyclins. And as the name gives you a hint, as we talked about earlier, cyclins are going to be appearing cyclically. So whenever we are talking about the cell cycle and the regulation, we need to be familiar with certain cyclins and the kinases which they are going to activate. Now cyclins can be of different subtypes. The first example of a cyclin is cyclin D. It is going to work in association with the kinase that is CDK4 and 6. The second important cyclin which is going to be appearing is going to be cyclin E, that is going to be activating the CDK2. The next one is going to be A, that is going to be CDK2 and 1, and the final one is going to be cyclin B, which is going to be causing activation of CDK1. So we understand the fact, and this is the exact sequence in which the cyclins are going to be appearing. So I told you as well earlier as well, D, E, A, B respectively causing activation of 4, 6, 2, 2, 1 and 1. That's a very high stuff that they are going to be asking you in the exam. Now, under normal circumstances, we are aware of the fact RB gene is going to be an example of a tumor suppressor gene. But whenever there is going to be a phosphorylation of the RB gene, it is going to forget its activity of suppressing, and now it is going to be responsible for causing initiation of the cell replication. Therefore, RB gene is what is also going to be given the other important name of the governor of cell replication. In fact, it is also being given the other important name of the molecular on-off switch of the cell. So far as the G1S phase is concerned, that is the reason why I explained is talking about the P53 gene. The P53 gene which is going to be present, it is going to be given the other important name of the molecular policeman of the cell. As I explained you, it can be responsible for acting as a checkpoint at the G1S as well as at the G2. That means at the first checkpoint as well as at the second checkpoint. Now it has happened in the past that they have asked you the question in the single best option question that P53 is going to be exerting more importantly its influence on, and the answer that you need to remember over there is the first checkpoint. So essentially first checkpoint is under the regulatory control of the RB as well as the P53, whereas the second checkpoint is going to be under the regulatory influence of P53. When we talk about the P53, we need to be familiar with the fact that this can be inhibited because of the presence of something like the P21, which is going to be given the name of an inhibitor. We'll just come to that in a couple of minutes. Talking about P53 gene, it is called by the name of guardian of the genome. Now suppose I tweak the question and ask you the fact which of the following is an example of new guardian of the genome. Read the question carefully. That is the name that is going to be given to the P10. So guardian of genome is P53. The new guardian of genome is the name given to the P10, about which we shall be talking about subsequently, the one that we associate with endometrial carcinoma as well as thyroid cancer. When we are talking about P53 gene, it is the unmutated type, the normal P53, the so-called gene present in urine my cells, which is going to be given the name of the wild type. So P53 gene essentially which is present in an unmutated form is the wild type. That is what we need to have an idea. Now looking at the example of certain types of inhibitors about which the questions are going to be asked in the exam, we are going to be asked questions with regards to three important types of inhibitors: P21, P27 and P57. Why P21 becomes important is because this is the one through which the inhibitory action of the P53 gene is going to take place, and we have talked about that in detail. You see, what happens is if because of any reason there is an alteration in the DNA, there is a DNA mutation, the P53 gene will like to cause a cell cycle arrest. The way it is going to be doing that is that P53 gene is going to increase the activity of P21. This is going to be an example of a cyclin inhibitor. So the cell cycle is going to halt. It will then employ certain genes which are DNA repair genes for repairing the mutated DNA. If the DNA repair is successful, very well and good. If for some reason it is unsuccessful, the P53 gene is going to initiate apoptosis. So we have talked about the role of P53 with respect to its association with inhibitor. We did make a mention of that in the main videos as well in association with apoptosis, and we need to understand that overall it is going to be a very important protective gene, because any kind of a mutation, if at all taking place in the cell, the P53 gene will try its level best to correct it. If it cannot be corrected by any means, of course the mutated cell is going to be undergoing the process of apoptosis. So for that very reason we were giving it the other important name of the guardian of the genome, not to forget the new guardian of the genome, which is going to be P10. Now having a revision about the genes which are going to be involved in carcinogenesis, we did make a mention of the fact that there are going to be four important categories of genes which are involved in carcinogenesis. They are respectively the proto-oncogenes, the tumor suppressor genes, the genes regulating apoptosis, as well as the genes which are going to be associated with the function of the DNA repair. Whenever we are going to be talking about the proto-oncogenes, as and when they are going to get mutated, they become overactive and they are going to be getting converted into oncogenes. So what we find in case of proto-oncogenes is that there is going to be a gain of function so far as the development of cancer is concerned. With respect to something like tumor suppressor genes, there is going to be a loss of function in them. The other important difference that we can recall over here is that even if there is a mutation in a single proto-oncogene, that can possibly result in development of a tumor. But when we are talking about the tumor suppressor genes, there has to be knocking off of both the copies of the genes. So that is what is going to be given the name of the Knudson's hypothesis. Knudson's theory or the Knudson's hypothesis, both the copies of the tumor suppressor genes should become non-functional. Only then the individual is going to be suffering from tumor. Of course, we can be talking about certain important examples of the proto-oncogenes which are going to be asked in the exam. So these examples of proto-oncogenes would include the cis gene. This is an example of gene that we did make a mention of earlier, that is going to be associated with development of brain tumors, CNS tumors, particularly astrocytoma, as has been asked as a question in the exam earlier. When we are talking about the second one, this is ERB1 and 2 gene. ERB1 gene is the one which is going to be associated with development of lung cancer. ERB2 gene is what is going to be associated with, the second name for that is going to be, it is going to be associated with HER2 receptor, and therefore it is easy for you to understand and recall. This is the one which is going to be associated with development of breast cancer. When we are talking about the red gene is the one which is going to be associated with development of a condition which is given the name of MEN2 syndrome. If you have already watched the videos in the main endocrinology section or in the RR section, you would be able to recall MEN2 is going to be having two variants, MEN2A and MEN2B. MEN2A is going to be associated with medullary thyroid cancer, pheochromocytoma, and the patients are also going to be having the presence of a parathyroid trouble. MEN2B syndrome or MEN3 as it is called now is associated with presence of medullary thyroid cancer, pheochromocytoma. You would be having the patient having a marfanoid habitus. He could be having the presence of mucosal neuromas. Whenever we are talking about something like the KIT gene is going to be associated with development of a tumor which is going to be arising inside the stomach, the mesenchymal tumor, GIST tumor, the commonest clinical presentation being something like gastric bleeding, which is being diagnosed with the help of something given the name of PET CT scan and is going to be having the expression of DOG1. So all those key terms associated with the KIT that you need to remember with respect to something like the gastrointestinal stromal tumor. As and when we are making a mention of something like the RAS gene is going to be associated with different subtypes. The KRAS gene is the one which is going to be associated with colon cancer. We could be having the presence of the HRAS gene associated with the bladder cancer and the renal carcinoma. That is what we need to remember. And of course, we can be talking about something like the NRAS gene, which might as well be associated with the development of neuroblastoma. Having a look at ABL gene, the ABL gene can be mutated in association with a gene which is going to be given the name of the BCR gene. That can be seen in a patient suffering from CML or a patient suffering from ALL. When there is a translocation 922 associated with ABL, that is going to be associated with a good prognosis in CML, and when it is going to be associated with ALL, that is usually going to carry a poor prognosis because of the fast rate of differentiation and the poor response to the anti-cancer agents. Talking about the MYC gene, we need to be familiar with the fact it is the c-MYC gene which is going to be associated with the development of Burkitt's lymphoma, as and when we are talking about the L-MYC gene, this is going to be associated with development of lung cancer, and we are talking about the N-MYC gene, that is the one which is going to be associated with neuroblastoma. Cyclin D1 is what is going to be associated with development of a tumor which is going to be given the name of mantle cell lymphoma. Mantle cell lymphoma, we need to be familiar with the fact that mantle cell lymphoma is having, the reverse is what they ask you as a question, cyclin D as a marker. However, there is a possibility that in some patients having mantle cell lymphoma, cyclin D1 may be absent, and if there is a negative expression, that means if the cyclin D1 is absent, the next best marker that you have to identify in the exam is going to be something like SOX11. So for mantle cell lymphoma, it is a SOX11 which is going to be working as a marker. So far as the next set of genes is concerned, which is going to be the tumor suppressor genes. The tumor suppressor genes are going to be having a loss of function, and therefore whenever there is going to be a loss of heterozygosity, which practically means that you have got one normal copy, you have got another normal copy, that is a situation in you and me. If there is going to be one gene which is non-functional, there is no development of tumor, but this is a heterozygous state. But if both of them become mutated, both of them become dysfunctional, now there is a loss of heterozygosity, and this is what is going to be responsible for development of cancer in the patients. So far as these kind of genes are concerned, the examples can be including something like the RB gene, which is, as we discussed few minutes back, the governor of cell replication or the molecular on-off switch of the cell. This is going to be associated with an important ocular tumor that is going to be given the name of retinoblastoma. As and when we are talking about something like the NF1 and the NF2 gene, the NF1 gene is going to be having its location on the long arm of chromosome 17. NF2 gene is having its location on the long arm of chromosome number 22. NF1 gene is associated with development of a condition given the name of von Recklinghausen's disease, neurofibromatosis. There is presence of caffeolate spots, there is going to be presence of least nodules. When you are talking about NF2, this is going to be associated with development of schwannomas, and the common question asked in the exam is with respect to a tumor which is given the name of acoustic neuroma. If you watch the videos in CNS as well as in neoplasia, in the main section you may be familiar with the terms the Antony A area, Antony B area, and the Verrucke bodies. If you aren't familiar, I would recommend you highly to go into the section of the CNS tumor video and have a look at it. When we are talking about APC, the APC is the one which is going to be given the name of, that is called by the name of the gatekeeper of colonic neoplasia. So different terms that you need to be familiar with. Governor of cell replication was RB. Gatekeeper of colonic neoplasia is the term that you are going to be using for the APC, and that is going to be having its location on the long arm of chromosome 5 associated with the development of colorectal cancer, because the APC gene can be associated with development of a large number of adenomatous polyps. When we are talking about the VHL, that is a von Hippel-Lindau syndrome, the gene is located on chromosome 3p, associated with development of a triad in which patients can be having renal cell carcinoma, they could be having the presence of CNS tumors, they could be presence of retinal angiomas, they could be presence of the manifestation, say for example, the cerebellar hemangioblastomas as well as leiomyomatosis. When we are talking about CDH1, this is given the name of E-cadherin. An E-cadherin gene mutation can be seen in a patient suffering from stomach cancer, that can also be seen in a patient suffering from breast cancer. So far as BRCA1 and 2 is concerned, they are example of important tumor suppressor genes, but they are going to be having an important function that has been asked in the exam. These are going to be having a DNA repair function. More commonly, we need to understand the BRCA1 gene is going to be associated with development of cancer in the ladies. And when we are talking about the BRCA2 gene, that is going to be more commonly associated with development of cancer in case of males. Both BRCA1 and 2 can cause cancer in both the sexes, but in females, we have more strong association with BRCA1. In male breast cancer, there is a stronger association with BRCA2. That is what we need to have an idea. Now, having said that, we need to be familiar with the genes which are going to be associated with the regulation of apoptosis, and therefore we talk about the P53 gene. Any mutation in the P53 gene at a germline level can be responsible for enhancing the risk of multiple types of cancers in the affected individual. That is given the name of Lee-Fraumeni syndrome. One of the ways by which you are going to be making a diagnosis of the Lee-Fraumeni syndrome was an INI question. This is what is going to be given the name of the Chomperet's criteria. The Chomperet's criteria is what you associate with an individual suffering from Lee-Fraumeni syndrome. Another important example of a gene which regulates apoptosis, which was asked in the NEET PG exam, is BCL2. Overactivity of BCL2 is going to contribute to the development of a tumor which is going to be given the name of a follicular lymphoma. That's another important tumor about which we need to have an idea. Talking about the fourth and the final category of genes, which are the DNA repair gene defects. When we are talking about the DNA repair genes, they can be subdivided into the categories of mismatch repair genes. That should be acting almost like a quiz for you, because I presume by this point of time you have watched the main videos quite a number of times, you have gone through your notes and revised them well. Mismatch repair is going to be seen in case of an individual suffering from Lynch syndrome. So increased risk of development of colon cancer, increased risk of development of ovarian cancer, increased risk of development of endometrial cancer. This is an example of a condition having an autosomal dominant mode of inheritance. A second one I can talk about over here is a defect at the level of the nucleotide excision repair genes. Now, if you are going to recall that, that is going to be really good. Nucleotide excision repair gene defect is going to be a finding that you would associate in a patient suffering from a condition called as xeroderma pigmentosum. So exposure to ultraviolet light is going to be responsible for enhancing the risk of development of skin cancers in these patients. The third important category of the DNA repair genes that we need to be having an idea is homologous recombination repair genes. And when we are talking about homologous recombination repair genes, three conditions that you need to be familiar with over here, that would include the Bloom syndrome, the Fanconi's anemia, and the ataxia telangiectasia. So all in all, what is appearing on your screen is an extremely high piece of information so far as the defect in the DNA repair genes is concerned. So mismatch repair Lynch, nucleotide excision xeroderma pigmentosum, and homologous recombination repair genes Bloom's, Fanconi's, and ataxia telangiectasia. So that is what we need to have an idea so far as involvement of the four different subtypes of the gene categories are concerned, and I've tried to summarize the examples of each one of you to the best possible of my abilities in the shortest possible time. Now, talking about some of the points which can be actually boosting your ranks by leaps and bounds, the first important point I would like to highlight over here happens to be what is given the name of chromothripsis. Chromothripsis is what is also being given the name of chromosome shattering. So I did explain to you that imagine a situation that there are multiple types of chromosomes, and these chromosomes are going to get broken down and then they refuse in a haphazard fashion. So that is what is going to be given the name of chromothripsis, which is therefore going to allow a lot of genes to malfunction. Now that kind of phenomenon of chromothripsis can be seen in case of bone tumors as well as in case of CNS tumors. When you talk about the example of the CNS tumor, you need to remember about the example of glioma. When you are talking about a bone tumor, we read it often in context of a tumor which is going to be osteosarcoma. A second important example of a high concept which is given in the book happens to be oncogene addiction, which talks about the fact that tumor cells are going to be totally dependent upon the protein product which is going to be produced because of fusion of a gene. So say for example, we are talking about a tumor that is going to be given the name of CML. This is going to be associated with translocation 922. Therefore, you are going to be having fusion of these two genes, the BCR and the ABL, Philadelphia chromosome, and the protein product of this fusion gene is going to drive the proliferation of the CML tumor cells. If by some mechanism you are able to reduce the activity of this protein product, the tumor cells are just not able to survive, and that's exactly what we do when we talk about the concept of targeted therapy for CML. In fact, that is going to be an applied pharmacology question. The drug imatinib was the first important example of a clinically useful drug which worked on the concept of targeted therapy, and therefore it kind of tapped the potential for what is being given the name of oncogene addiction. A third important term I would like you to be familiar with over here happens to be differentiation therapy. So say for example, certain vitamins like vitamin A or retinoic acid are responsible for differentiation of the cells. Now for some reason, if vitamin A is unable to function, that can be responsible for the presence of undifferentiated cells, and this is what is going to be giving rise to a tumor that is given the name of AML-M3, also given the name of acute promyelocytic leukemia. As a result of this, the patients are going to be having a high risk of suffering from either a condition like DIC, or they can be having a development of a condition like migratory thrombophlebitis. Because of DIC, the patients used to die. Now, when we understood about the concept of differentiation, we started providing vitamin A from outside. So, we started giving to these patients what is given the name of ATRA therapy, all trans-retinoic acid in high amounts, and that resulted in better differentiation of the cells and therefore treatment of the patients. So that is what is going to be given the name of differentiation therapy, and you need to remember the name of the tumor by which you are going to be associating this kind of a therapy, that would be associated with the acute promyelocytic leukemia. We also need to be familiar with the other important thing, that would be with regards to epigenetic changes. Epigenetic changes are going to be example of changes which typically are going to be associated with two important findings. Either we talk about something like DNA methylation, or we talk about something like acetylation change in the histones. So there are specific examples of tumors that we keep on talking about, including the myeloid differentiation problems, the myelodysplastic syndrome, where epigenetics are going to be playing a role. In fact, in the current times, I did share with you an example of a list wherein I specifically talked about the presence of different types of gene, example the MLL gene, and the different types of tumors in which the epigenetic changes are going to be playing a critical role. The final important term I would like you to highlight over here is tumor lysis syndrome, in which we have is rapidly dividing tumor cells, especially on the administration of anti-cancer agents, could be having a damage to the cells, which is going to be responsible therefore for causing an increase in the level of uric acid. There's going to be increase in the level of potassium, but there is also going to be a leakage of phosphate, which is going to be combining with calcium, and therefore the patients are going to be having the development of hypocalcemia. So quite commonly asked question in the exam regarding the electrolyte disturbance, which is expected to be seen in case of an individual suffering from tumor lysis syndrome. Yes, you're going to be having the presence of elevated amount of uric acid, you're going to be having more amount of potassium, you're going to be having more amount of phosphate, but what is going to get depressed over here is going to be calcium. Now typically true tumor lysis syndrome is going to be seen in case of patients when we are talking about the fast growing tumor like Burkitt's lymphoma, or when we are talking about a tumor like acute lymphoblastic leukemia. So those are the examples of certain high yield points that I wanted you to be having an idea about and kind of keep on revising so that you get a better rank at the level of the exams. Talking now about the etiological factors which can be associated with development of cancer. When we are talking about the etiological factors, there are three important types of etiological factors that we did make a mention of earlier, friends. There were example of certain types of chemicals which are responsible for causing development of a cancer like carcinogens. These carcinogens can be tested with the help of a test which is responsible for performing or knowing about their mutagenicity, which is given the name of Amy's test. So Amy's test employs the use of a bacteria which is going to be given the name of Salmonella typhimurium. And using this particular bacteria, as explained you in detail in the main video section, you could be testing whether a particular chemical can be responsible for inducing mutations or not. Cancers can also be caused because of radiation exposure. They can also be caused because of exposure to microbes. Now, there are different types of chemical carcinogens which have been implicated and which have been asked in the exam quite commonly. The important list is what is appearing on your screen as of now. So, when we are talking about something like aflatoxin, that is going to be responsible for development of hepatocellular carcinoma. This is an example of a toxin produced by the peanuts, and those are the hints given in the exam. Peanuts which are being contaminated by a fungus given the name of Aspergillus flavus. When you're talking about nitrosamines are going to be causing contamination of the water. So when the people are consuming water in a particular geographical area which is going to be unfiltered, that has been supposed to be increasing the risk of development of GI tract cancers. The moment we are talking about something like asbestos, it has been highlighted because that's the most frequently asked question in the exam in recent times. Asbestos exposure can be associated with development of bronchogenic carcinoma. Especially the question asked in the exam is which particular subtype, that is adenocarcinoma. It is associated with development of malignant mesothelioma, is associated with development of renal cell carcinoma, can be associated with development of something like a laryngeal cancer as well. The most specific cancer caused because of asbestos exposure is to be answered in the exam as malignant mesothelioma, whereas the commonest one in context of lung is to be answered as bronchogenic carcinoma. The question in context of vinyl chloride is going to be with respect to the kind of cancer caused because of this. That is again supposed to be answered in the exam as hepatocellular carcinoma is not to be ticked up. It is a liver cancer, but I did make a diagram of a liver, but the answer is not hepatocellular carcinoma. The answer I wanted to be clear of over here is going to be angiosarcoma. So angiosarcoma, as I told you earlier as well, can be associated with exposure to plastics, including polyvinyl chloride, as well as in because of something like thorotrast, as well as you need to be familiar with exposure to a heavy metal like arsenic. When you are talking about diethylstilbestrol, an example of a chemical which is still being asked, but that is associated with higher risk of development of vaginal carcinoma. And when we are talking about something like cigarette smoke, perhaps one of the commonest reasons for development of carcinoma in the current times, that can be associated with the increased risk of development of multiple cancers, including the liver cancer, including the lung cancer, including the presence of GI tract cancers, including the presence of kidney cancer, including the presence of urinary bladder cancer. Typically, with respect to lung cancer, they love to ask you the specific problem in the smoke which is going to be causing a trouble. That will be answered as polycyclic aromatic hydrocarbon. One specific example of a polycyclic aromatic hydrocarbon which is implicated in the development of urinary bladder cancer is supposed to be remembered as beta-naphthylamine. Beta-naphthylamine. Now, the other important one which has been asked in the exam is that we are talking about an individual residing in a big city, and this individual is being exposed to air pollution, because of which he is going to be having exposure to benzene. Benzene is coming actually from the either the people who are going to be working in the hydrocarbon factory, or it is going to be present in the exhaust fumes from the automobiles. So this has been implicated in the development of blood cancers or leukemias. That is what is very important. That is what we need to keep in an example of the list which is high yield from the perspective of the exam. The second important example of the etiological factors can include radiation exposure. Radiation exposure can be in the form of UV rays. UV rays can be responsible for causing skin cancer. So whether we are talking about something like a basal cell carcinoma, or we talk about a squamous cell carcinoma, or for that matter, there are certain conditions which we discussed 2 minutes back which increase the risk of development of skin cancer in case of an individual. Say for example, a person is suffering from a condition like xeroderma pigmentosum. So UV exposure can be enhancing the risk of development of skin cancer in such patients. We need to remember the fact that radiation exposure is not likely to be associated as a risk factor in case of a patient suffering from chronic lymphocytic leukemia. On the other hand, if you are talking about a question asked in the exam wherein they talk about a young individual who has been exposed to radiation, and particularly the kind of radiation we are talking about over here is ionizing radiation. Say for example, people residing in vicinity of Hiroshima, Nagasaki, or during the Chernobyl disaster, they are the ones which are going to be at higher risk of development of the papillary thyroid cancer. So depending upon the kind of question that they are putting up to you in the exam, you will answer it accordingly. As and when we are talking about the microbes, it is the viruses which are going to be the most dangerous. 6 important types of viruses which are going to be asked in the exam quite commonly: RNA virus, which is HCV virus, responsible for development of hepatocellular carcinoma. Similar would be true in case of hepatitis B virus, responsible for causing development of hepatocellular carcinoma, because this is going to expose the hepatic tissue cells to the HBx, which is an example of an oncogenic protein. At the same time, chronic inflammatory change induced by the hepatitis viruses B and C are responsible for setting up the soil for regeneration. When there is a regeneration, there is a possibility cells can have a spontaneous mutation, and that enhances the risk of development of cancer. There can be another important virus by the name of HTLV1, which is implicated in the development of adult T cell leukemia, an example of a cancer affecting the CD4 T cells, particularly in the Caribbean islands. That is what you need to remember. Another one which is loved by examiners is Epstein-Barr virus, implicated in the development of Hodgkin's lymphoma, non-Hodgkin's lymphoma, Burkitt's lymphoma, as well as nasopharyngeal carcinoma. The next one that we need to have an idea is Kaposi sarcoma herpes virus, which is the one which is going to be implicated in the development of Kaposi sarcoma, one of the AIDS defining malignancies which is commonly asked in the exam. So HCV and STLV, they are RNA viruses, whereas we talk about hepatitis B virus, Epstein-Barr virus, KSHP, they are example of DNA viruses. Of course, we cannot forget the role of human papilloma virus, especially the high-risk subtypes 16, 18, 31, 33 in the pathogenesis of oropharyngeal cancers, in the pathogenesis of rectal carcinoma, in the pathogenesis of cervical cancer, and that is because of the fact that this is an example of a sexually transmitted virus. Now in the exams, they sometimes ask you about the oncogenic proteins or the role played by them. So in context of Epstein-Barr virus, the role is being played by latent membrane protein 1. In case of hepatitis B virus, the role is being played by HBx. In case of something like the other viruses, say for example the human papilloma virus, we are going to be having the role that is going to be played by, that has been a recent exam question, the role that is being played by E6 and E7. The E6 is responsible for interfering with the activity of P53, whereas the E7 is responsible for interfering with the activity of the RB gene. So because P53 and RB, both of them are example of genes which are going to be associated with P53 example of guardian of genome, and RB is an example of a tumor suppressor gene. So if their activity is interfered with, that enhances the risk of development of cancer. So remember the fact, E6 interferes with activity of P53, E7 interferes with activity of RB, and that is going to increase the risk of development of cancer. So that is what we need to have an idea so far as the viruses are concerned. Of course, we can be talking about the dangerous bacteria like H. pylori, which can increase the risk of development of gastric adenocarcinoma as well as moltoma. We can be talking about certain types of parasitic infections, say for example schistosoma, which is implicated in the development of the urinary bladder cancer. A kind of fluke, the liver fluke, can be associated with development of cholangiocarcinoma as well. So the point is that exposure to different types of chemicals, exposure to radiation, exposure to microbes, any of them can be possibly over a period of time can be associated with development of cancer in context of human beings. Talking about and having a quick recap of the paraneoplastic syndromes, when we are talking about hypercalcemia, that can be seen in a patient who is going to be suffering from the squamous cell carcinoma, especially the squamous cell carcinoma of the lung, as well as it can be seen in patients suffering from breast cancer. We need to be familiar with the commonest cancer which is going to be responsible for causing hypercalcemia, that is the squamous cell variant of the bronchogenic carcinoma. Why we are talking about hypercalcemia over here is because of the fact that there is going to be a secretion of a molecule given the name of the PTH related peptide by the tumor cells in case of lung as well as breast cancer, and that is going to be responsible for causing development of the hypercalcemia. Incidentally, this hypercalcemia is going to be the commonest paraneoplastic syndrome that is observed clinically. A second important example of a paraneoplastic syndrome happens to be Cushing syndrome, which is associated with development of the small cell cancer of the lung, because the small cell cancer of the lung is going to be having the presence of neurosecretory granules, and they are the ones which are responsible for secretion of an ACTH like substance. Third one happens to be polycythemia, quite commonly asked in the exam, implicated because of development of a patient suffering from renal cell carcinoma or hepatocellular carcinoma, or at times even with tumors like the cerebellar hemangioblastoma. The fourth one that we need to have an idea is SIADH, associated with small cell cancer of the lung, again for the same reason. The neurosecretory granules at times are responsible for the secretion of vasopressin or ADH, and that is going to be responsible for causing the secretion of excessive amount of ADH. The fifth one that we need to have an idea is hypoglycemia, slightly forgotten more frequently in the exams, but then the cause is because of fibrosarcoma, mesenchymal tumors, as well as certain hepatic tumors have also been implicated in the development of hypoglycemia. The next one happens to be acanthosis nigricans, wherein you would find the individuals are going to be having the presence of hyperpigmentation attributed to the release of factors from the stomach cancers and the tumor cells in a patient suffering from lung cancer. The moment we are talking about myasthenia gravis associated with the tumor like thymoma, although the thymoma can be associated with other troubles in the patient as well apart from myasthenia gravis, thymoma patients can be having the development of pure red cell aplasia, a recent NESET question. It is also implicated in association with hypogammaglobulinemia, and that was also a PG exam question asked relatively recently. The next one we need to have an idea is Lambert-Eaton syndrome, which is going to be associated with a patient suffering from the small cell lung cancer. Finally, we just wrap up the discussion by talking about the lesser Trellard sign, which is seen in a patient having seborrheic keratitis, for which I showed you an image as well. And we are going to be having its association with something like the stomach cancer. So the presence of lesser Trellard sign, in fact seborrheic keratitis, should alert a physician or in fact a dermatologist as well, that the patient could actually be having the presence of a hidden underlying gastric malignancy. So that is what we need to have an idea so far as the paraneoplastic syndromes are concerned. Talking about how exactly are we going to be making about diagnosis of cancer, we can just quickly revise the fact that diagnosis of the cancers can be done with the help of something like FNAC. When we are talking about FNAC, we need to be familiar with the fact that the commonest needle size that is being used for carrying out FNAC is between 20 to 26 gauge needle. Now FNAC may be giving you a hint with regards to the presence of a tumor, but then for certain kind of malignancies we need to remember that FNAC is not going to be useful. Say for example, we are talking about differentiation between a follicular adenoma of the thyroid, which is a benign tumor, and a follicular carcinoma of the thyroid, which is an example of a malignant tumor. So in such situations, and that's a commonly asked question, in such situations what we rely on is the demonstration of presence of metastasis. So if you demonstrate the presence of metastasis, say for example, by showing the metastasis causing involvement of the blood vessels in the capsule of the thyroid, that is going to be confirmatory. So FNAC is a good investigation, easy to carry out in the OPD, but then it is not going to be helpful in making a diagnosis of all the cancers. And especially remember the fact that for differentiating between a benign and a malignant pheochromocytoma, differentiating between a benign and a malignant follicular thyroid tumor, we are not going to be relying upon FNAC. The other thing that they talk about recently in the exam about FNAC was with regards to something like thyroid only. It reminded me of the fact that they talked about the adequacy of FNAC. So we need to have an adequacy of FNAC in the sense that we need to have at least the presence of 6 groups of cells which are going to be consisting of 10 follicular cells each. 10 follicular cells each. So that is the adequate sample that we are going to be talking about whenever we're looking at the FNAC from a thyroid. 6 groups of minimum 10 follicular cells each. That is what is going to decide the adequacy of the sample in context of FNAC. The other important thing that we need to be familiar with over here is for making a diagnosis of cancer can be exfoliative cytology. Exfoliative cytology is pretty useful. Say for example, when you are talking about something like a buccal smear, or when we are talking about the gynecological malignancies, for which I would recommend you to be familiar with something like pap smear very thoroughly. Now when we are talking about pap smear, the first thing which comes to our mind visually would be the presence of an IR spatula, and we are going to be talking about taking the scraping over here that is going to be taken from the squamocolumnar junction. In fact, they asked you the steps in the ANICET exam for taking a pap smear. So you would ask the patient to lie down, obviously spread her legs. You would be taking the scraping from the squamocolumnar junction, take it out and put it on a slide, and then you're going to be fixing it. So far as the fixation is concerned, the fixation is done with the help of a combination of ether plus 95% ethanol. Now what they've asked you in the exam earlier is, and that is going to be kind of a tricky information, that sometimes contamination is expected to take place in solid cancer biopsies, and therefore we need to remember the fact that in such situations conventional cytogenetic analysis becomes difficult. So there are two things that we are talking about over here. One, we are talking about the pap smear, the methodology and the fixative being used. And the second thing that we are talking about over here is that sometimes in a lot of solid cancer biopsies, there would be a high degree of contamination, because of which the conventional cytogenetics is going to become difficult. So that is just a fact-based point. In case it is repeated, you need to be familiar with that fact. Talking about the third method by which we can be making a diagnosis, that could be something like the immunohistochemistry. Now immunohistochemistry is going to be very useful these days because of the fact it can be useful for making a diagnosis in case of a tumor. Say for example, we are going to be using certain markers, for example something like the cytokeratins. We are going to be using immunohistochemical chemistry in the deciding the origin as well, for which I did show you this kind of a tumor wherein talk about the cytokeratin 7 and cytokeratin 20. Depending upon the fact whether both of them are going to be positive, only one is positive, whether it is 7 or 20 or both of them are going to be negative, you can be making a tentative diagnosis about the carcinoma of the unknown primary. So relative idea would be available to you where exactly can you expect to have the primary when you are talking about something like the cytokeratin 7 and 20. Similarly, when we are talking about something like the presence of the prognostic and therapeutic significance, best highlighted in case of breast cancer, especially when we are talking about the breast cancer which is going to be having an association with HER2/neu. So there is a possibility that patients are going to be having the presence of HER2/neu. If HER2/neu is present, in general that is a relatively more aggressive cancer, so prognosis is relatively poor, and the therapeutic significance lies in the fact that now we have got a targeted anti-cancer drug against the HER2 receptor, that is trastuzumab, and therefore we are going to be using the drug only and only if we are able to demonstrate the presence of the HER2 receptor expression. So prognostic significance as well as therapeutic significance is both available with regards to something like some of the immunohistochemistry markers. Of course, we can be talking about certain important markers which are going to be asked in the exam. Say for example, if I am making a mention of something like cytokeratin would be telling me with regards to the origin, it is going to be associated with carcinoma. If you are going to be talking about a tumor which is going to be given having a marker like vimentin is going to be associated with a mesenchymal tumor like sarcoma. If I am talking about something like desmin, which was asked in the exam as well, desmin is going to be talking about something like a muscle tumor. So they give you a question on rhabdomyosarcoma. In fact, the question was that the patient was having the presence of a orbital mass. There was a child having orbital mass. The biopsy was done and they did find the presence of a desmin, so suggestive of something like a rhabdomyosarcoma. And of course we can be talking about certain other factors, say for example glial fibrillary associated protein, that is going to be associated with a tumor like an astrocytoma or a CS tumor. So cytokeratin, vimentin, desmin, GFAP, they all can be useful for tentatively talking about the nature of the tumor which you are going to be examining under the slide. Another important technique that we need to have an idea is given the name of lymph node imprinting, which is going to be useful for making a diagnosis of malignancy, in which you are going to be cutting the lymph node and obviously imprinting it on the slide and then doing the histological examination. And finally, we need to be having an idea about the tumor markers. Now, when we are talking about tumor markers, I would request you to go back and watch that particular video wherein I talked about the classical tumor marker as well as the novel tumor markers. And the important thing that I would like to highlight over here is the tumor markers are going to be used as accessory tools for the diagnosis of a cancer. I mean, what I want you to remember very categorically is they are never ever useful for confirmation of a cancer. So you have to see the complete picture. You have to understand the fact that there is going to be a demonstration of something like the histological changes that you can be observing under the slide. That can be confirmatory. The biopsy examination can be confirmatory. Tumor markers would be giving you a hint with regards to, they will increase your suspicion whether the patient is going to be having a tumor. Of course, the higher the tumor marker, most of the times that can be very well correlating with the size of the tumor as well. It becomes all the more significant when you offer a therapy regime to the patient, be it a surgery, be it a radiotherapy, be it an anti-cancer drug. So you can see the response that you are going to be getting with the therapy that you have administered. So for all those purposes, yes, I would say tumor markers are going to be extremely important. But what I again would like to highlight is, and that's going to be a kind of a negative point that you need to keep in mind, it is not for confirmation of a tumor. So lot of tumor markers that we keep on talking about, say for example neuron specific enolase in association with something like the adrenal tumor. We talk about something like the beta HCG for choriocarcinoma, prostate specific antigen. The newer ones that we need to be having an idea, say for example a MECR NKX31. So I request you again to go back into the main video section and do have a look at the new tumor markers as well as the classical tumor markers that they are likely to be giving to you in the exams for the purpose. That is what is going to take care of our discussion of the neoplasia topic.